So good morning, everybody. Good afternoon also, and good evening from all the part of the world. Professor Wee, Professor Zhu, thank you for being here. So we can start on time. Are you ready?
Yeah, I will
Okay.
show my screen. Okay.
I will introduce you first, then we can
Yeah.
continue. So we will
Thank you.
start. Thank you for you. So, good morning, everyone. Good afternoon and good evening also. And welcome to this day two of our webinar. I am Issam Benis from the University of Mohammed VI of Science and Health, located here in Casablanca, but also in different parts of Morocco. And I have the pleasure of moderating the session 5 on One Health and infectious diseases. This session brings three strong contributions from China and Indonesia, exploring infectious disease emergence through complementary lenses, pathogen surveillance, governance frameworks, and also environmental drivers. Three 30-minute presentation will be followed by a round table panelists. Please keep microphone muted unless presenting. And attendee, you are welcome. And please use the question answer panel. I will collect a question from the round for the round table, of course. So now it's my pleasure to introduce Dr. Hook-Jin Wee. It is now the first speaker, Dr. Hook-Jin Wee, who holds a PhD from the School of Public Health at Xiamen University in China. His research focuses on vector-borne infectious diseases, and today he will present on escalating transmissibility of severe fever with thrombocytopenia syndrome and its One Health implication. So, Dr. Wee, the floor is yours. You can share your screen at any moment.
Thank you. See. Oh. Can we see the screen in the PowerPoint?
Okay.
Okay. Thank you very much, Professor Benis, for your kind introduction. Wait a moment.
First,
And there's
I will.
something wrong with.
Okay. So now you can share your presentation.
Yeah. Wait a minute. Is it okay?
Not yet.
Oh.
Yes. Now
Okay.
we are showing your main screen, but not,
Yeah.
perfect. So,
Oh. Okay. It's wrong with the PowerPoint. Sorry. Thank you very much, Professor Benis, for your kind introduction. Distinguished chairs, professors, doctors, researchers, and colleagues. Good morning, good afternoon, and good evening. Welcome to the Global Health webinar. My name is Hongjie Wei. I came from Xiamen University in China. It's truly a great honor for me to be here to show my work with all of you. My current research focus on vector-borne disease, infection disease. Today, I will present our work entitled "Escalating Transmission of Severe Fever with Cytopenia syndrome and its One Health implication. Severe fever with cytopenia syndrome, or SFTS, is an emerging tick-borne infection disease in recent years. Its affect areas and public health relevance has been expanding. Importantly, SFTS is closely linked to multiple One Health dimensions, including environmental conditions, animal host and tick vectors, and human exposure. Therefore, SFTS should not be understood only as human clinical disease, but as a transmission system shaped by the interaction among humans, animals, vectors, and the environmental. In the presentation, I will use FSTS as an example to discuss how infection disease modeling, environmental factors, and One Health thinking can be connected for risk assessment and early warning. Before talking about SFTS, let me first begin with One Health framework on the right. The message of One Health is about human health, animal health, and environmental health are closely connected. A disease may finally be diagnosed in hospital, but its story often began much earlier in the environment, in animals, or in daily human activities. SFTS is a good example of this. It's a tick-borne disease, so its transmission depends not only on the virus, but also on animals' host, tick vectors, and environmental conditions and human exposure. Here on the left, we can see some possible animal hosts and rural exposure setting, such as hilly areas and farming and tea picking. These are exactly the place where human, animals, and ticks and environmental meet. Less is why SFTS fits very naturally into the One Health framework. To be better protect human health, we need to understand how disease develop in these human, animals, and environmental systems where the high risk area are and how transmission can control earlier. So in the following slides, I will use SFTS as One Health example to discuss its transmission and spatial distribution and control implications. To understand how SFTS reach humans, we first look at the life cycle of ticks. Like this, ticks usually develop through four stage: eggs, you can see it, eggs and larva and nymph and adults. The circle began and 12 female ticks dropped into the ground after feeding and lay eggs in the environment. This egg then hatch into larvae. To continue development, larvae need to find a host like this, find a host, and after feeding, they detach from the host and drop back into environment and mold into nymphs. The same process happen again in the nymph stage. Nymphs feed another host and detach and then mold into adult ticks. Adult ticks then feed and mate on a host, and the female eventually drop off to lay eggs, starting next generation. In other words, ticks ticks do not stay with one host for their whole life. They feed and detach and development in the environment, and they search for another host at next stage. The host switching process is very important for a One Health perspective because it creates ecological connection among animals, humans, and the environmental. The barriers can be maintained in the nature through the tick animal circle, when where humans may become where humans may become infected like this. Uh, mm, for humans, there are three possible routes of infections. We can see it. This is first one, animal contact. This is second, humans can can be bitten by adults like ticks, and humans can connect. And the third route is close connected. The third route is close connect with infected patients like this, especially through the broad. This is why high-risk population are usually people who work outdoors or have frequent connect with rural environment. In our retrospective investigation like this, farming accounting 60.9% of exposure, and grass cutting accounts for 23 point percent. Together, together these two activities account for 84.5% of reported outdoor activities because this is one set. So SFTS risk is generated at the interface of ticks, animals, and the environmental setting and the human behaviors. So to control SFTS, we need to understand not only the virus itself, but also where people work, which animals are involved, and how ticks exposure happen in real life. After discussing transmission, the next question is what happens after a person is infected with SFTS virus? The clinical course of SFTS usually began with an incubation period of about 5 to 14 days. During this period, the patient may not have obvious symptoms. Then patients enter a field stage, which usually lasts from day 5 to day 11. Common symptoms include fevers, fatigues, headaches, muscle pain. One challenge here is that these early symptoms are very specific. They can look quite similar to common virus infections or even a command cold. So in areas where a doctor has limited experience with SFTS, it may be difficult to recognize the disease at the early stage, especially if the patient does not clearly report the tick, especially if the patient does not clearly report the tick bites or outdoor exposure. The table on the right summarize reported cases for because fatality rates from countries where SFTS has been most frequently reported, including China, South Korea, and Japan. The reported rate is about 5 to 15% in China and 15 to 20%, 25% in South Korea and 20 to 30% in Japan. This number reminds us that SFTS is not a mild tick-borne disease. The fatality rate is still relatively high, especially considering that many high-risk populations are older or involved in outdoor. This is another reason why early recognition and early diagnosis and One Health-based prevent are so important. After looking at the clinical circle, we can return to the ecological side of SFTS and ask a very practical questions. Where can the main vector survive and spread? The map here focus on here what focus on hemisphereness and logicalness, which is considered one of the major ticks vector for SFTS transmission. The upper map shows it report geographic distribution. We can see that this tick has been recorded in several regions, especially in East Asian and also in some areas outside Asians. If we look more closely at Asian, China is one of the important areas for these vectors. The road map shows habitat suitability, and we can see that suitable areas are widely distributed in China. This means that the ecological conditions in many parts of China may support the survival and activities of this tiki. And this is also one reason why China provides a very useful seeding for starting SFTS. The vector is present, suitable habitat is relative broad, animals, hosts, and rural environmental are common. And human outdoor exposure still occur in many regions. Together, this focus create a real world One Health setting for understand how SFTS emerges and spread and can be controlled. Reported distribution tell us why the tickets has already observed well habitat suitability tell us where environmental condition may favorable for ticks to survive. This condition may include temperature, humidity, vegetation, land cover, and host availability. So the risk of SFTS is not defined only by where people case have already been reported. It also depends on where the vector can live, where animals hosts are present, and where human activities overlap with this ecological setting. For One Health perspective, this map gives us a bridge between environment and animals and vectors and human health. If a region has a suitable habitat for the tickets, active animal host, and a frequent outdoor human exposure, and then it may become a pollution high-risk area even before many human cases are detected. Therefore, understanding the distribution and habitat suitability of this ticket can help us move from passive case reporting to earlier ecological risk assessment and target surveillance. Yeah. This slide brings us to the study setting of our work, Anhui Province in China. And Anhui is located in eastern China, and in this study we divide the province into three geographic regions: North Anhui, North, Central, and Southern. This regional division help us to compare how SFTS differs across ecological and geography setting within some periods. The evolution map in panel B shows Anhui has a clear geography gradient. The north part is relative flat, white, while the southern and the south part include more hilly and motion areas. This is important for SFTS because TKs, the mergetic vectors we introduced earlier, is commonly associated with low to medium elevations and environmental, especially in hilly areas, grassland, rural vegetations, and humidity and temperature and host availability. Anhui province provides a very useful setting for studying SFTS. Is one of the province with a heavy SFTS burden in China, and it includes both plants and hilly ecological environment. It allows us to examine how human cases are distributed in relation to geography, environment, and possible vector habitat. The panopsis shows the annual extent of SFTS across different cities in Anhui from 2019 to 2023. We can see that the disease was not even distributed across the province. Some cities, especially the central and southern Anhui, rapidly shows higher higher instance over multiple years. This stress that SFTS has clear spatial heterogeneity and that some areas may have some favorable condition for transmission. From one health perspective, this area is not just a map of human cases. It combines landscape of human activities, animal host, and tick habitat, and environmental condition. That is why Anhui is good real-world setting for understanding where SFTS is more likely to occur and how targeted surveillance and control be designed. To make the ecological risk more concrete, we would like to brief take you to our field sample site. This photo show our TICS connection work in rural areas. The environmental is quite typical for tiki habitat. There is dense grass vegetation along fair land and water bodies and near hills. This setting provides a suitable microhabitat for ticks, and they also create frequent contact among humans and domestic animals, wildlife, and the environment. In fact, work like this, personal protection is very important. Ideally, we should wear protective clothing, long sleeves, gloves, and take measures to prevent tick bites. In this particular thinking show here, the collecting was connected in this month. Will ticket activities yet at its season peak, so the protections was not complete as it should be, but it also remained as the vaccine itself carries a real exposure risk. We connected ticks using like this flagging method. The white cross is struck and placed over vegetation, and cresting ticks attached to the cross as if they were try is uh, as if they were trying to find host. We then carefully connected the ticks from the cross and store them in tubes for later in identifications and testing. The photo on the right shows the tickets connected during one of our previous flagging surveys last years. As you can see, even a short field survey can connect it many ticks when the season and habitat is suitable. This field experience helps connect the model and the maps with real life. SFTS risk is not owning a number on a map. It's generally in this rural ecological setting where tickets, animals, vegetation, and human outdoor activities meet. That is exactly why One Health approach is needed. Now we will briefly introduce our study design and the epidemiology characteristics of SFTS in Anhui Province. The left part shows the overall workflow. We connected civilian statistical information and literature-based parameters, and based on this data, we conduct epidemiological analysis and transmissibility estimations, including epidemic trend and spatial distributions, population characteristics, and high-risk areas, and the basic prediction number. The right part summarizes the epidemiological patterns in Anhui from 2019 and to 2023. Overall, the number of reported SFTS cases shows an increasing trend year by year. The cases also show clear seasonality, yeah, and age-related patterns, and special difference across cities. So this part gives us epidemiology foundation of following transmission modeling and risk assessment. Following the start design, these figures show the modeling structures used for transmissibility estimations. We translate the One Health transmission process into a dynamic model, including people, ticks, and host animals within same natural environment. This reflects idea of that SFTS is driven by interactions among humans, ticks, animals, and the environmental setting. The model includes the main transmission route discussed earlier. For human, we consider infectious through tick bites, connect with host animals, and cross contact with infect patients. For ticks and animals, we include their transmission circle and the developmental stage of ticks, like level enough and adults. This structure allow us to link reported report human cases with ecological transmission process behind land and then estimate transmissibility through the bicycle production number. Yeah. Using the dynamic model and the next generation mixed method, we further calculate the basic population number or Arling for for Anhui province and for 5 cities within highest SFTS burdens. These figures help us visualize transmissibility more directly at the province level. Arling was below 1 from 2019 to 2021, but increased above 1 in 2022 and 2023. This stress that overall transmission potential of SFTS in Anhui was increased in recent years. At city level, the pattern is clear difference. For example, Chuzhou, like this a city of Anhui, shows relative high Arling values, especially from 2021 to 2021 to 2023, indicating a strong local transmission potential. Other cities also showed increasing value in different years. From One Health perspective, Arling is not a mathematic number. It reflects the combined efforts of human exposure, tick activities, animal host, and environmental conditions. So quantified transmissibility can help us identify when and where the human, animals, vector, and the environment systems may become more favorable for SFTS transmission. This provides useful evidence for targeted surveillance and early warning. From this study and from practical field work, we can summarize some useful lessons for SFTS lesson. For SFTS, we should not only ask how many persons do we have. A better question is what was happening before this patient appears. In many cases, human infections is not beginning of the story. This is the point where the story finally became visible to health system. Before that, the virus may already be moving quietly through ticks, animals, and the environment. That is why One Health surveillance is so important. Human case reporting give us one part of the picture, but it's not enough by itself. We also need animal monitoring, tick surveys, and some other information together. This data can tell us whether the local ecosystem is becoming more suitable for transmission. If we connect these singles, we can move for positive reporting to early warning instead of reacting only after patients are diagnosed. We can prepare before the peak season and focus on high risk villages and occupations and use prevention resource more efficiently. In short, SFTS surveillance should not be hospital considered. It should be a connected system across human, animals, vectors, and the environment. Less real One Health implication here. In summary, One Health perspective help us connected ecological evidence with practical surveillance and policy actions. This conclude my presentation. And thank you very much for your attention.
Thank you so much, Professor, for your presentation. Dr. Wee, this presentation, it was very interesting because it's the kind of presentation of the evolving epidemiology of FFSTS, the escalating transmissibility, and you describe it is precisely the kind of phenomenon that demand a One Health response. We will collect questions from the round table from the attendee. Please don't hesitate to ask your questions. Then we will return back during the round table. I invite you to stay with us, please, to be possible to interact on this round table and share some questions from the attendee and also from the other panelists. I now the great pleasure of introducing Dr. and Professor Yinling Zhu, Associate Professor at Xinyang Normal University in China. Dr. Zhu pursued joint PhD study at the University of Göttingen in Germany and received her PhD from Wuhan University School of Law in 2015. She subsequently spent 7 years at the Global Health Institute and the School of Public Health in Wuhan University, and later served as associate researcher at the Wuhan University Academy of International Law and Global Governance. So she has led the research funded by the Humanities and Social Science Foundation of the Ministry of Education of China, and serves on the Early Career Research Board of the International Journal for many journals. So her research focus on One Health governance and global health law, and exactly this is the focus of her presentation today, titled One Health Governance Theory, Practice, and Ethics. So Dr. Zhu, the floor is yours, please.
Thank you. Thank you for the kind introduction. I'll share my all points.
Perfect.
Okay. Good morning, good afternoon, good evening, everyone. It's a real pleasure to be here today. My name is Yinling Zhou from Shenyang Normal University. I'm honored to have the opportunity to present the latest work on One Health governance, theory, practice, and ethics. So imagine a world where we have the best outcomes for people, animals, plants, and our environment. How close are we to achieving this? In the next 30 minutes, I will address 3 key points. First, I will briefly outline the problem of One Health governance. Then, I will indicate theory and practical cases of One Health governance. Finally, I will share our main findings about ethics and ethical functions of One Health governance. As we know from previous work, there has been wide-ranging commitment to the One Health approach to enhance the pandemic prevention, preparedness, and response. However, there is a critical gap. Specifically, the implementation of the One Health approach has so far proven challenging. Besides, the ethical considerations may also arise during the One Health implementation because it is central to accountability, strategic planning, and effective health programs. Therefore, our objective was to explore how can One Health governance be effectively synchronized, practiced, and ethically implemented to enhance pandemic prevention, preparedness, and responses. To address this question, we first explore theory of One Health governance. Let's have a closer look at the theory foundations of One Health governance. Here, it is very much helpful to frame this issue through the lens of global public good theory. We argue that One Health approach is a global public good that invites governance to minimize the health of human, animals, and the environment by shaping interdisciplinary and cross-sectoral collaboration. Second, we further explore the theory of systems thinking because we can identify components, interactions, and feedback loops within One Health governance by analyzing relationships between human health, animal health, and environmental factors. The approach helped illustrate that how changes in one component can affect others. Furthermore, applied systems thinking may be fully and equally appreciated in policymaking and practice. This can strengthen the long-term One Health collaborations and health systems in low and middle-income countries in particular. Third, there is a strong relationship between good governance and One Health governance. If you look at this table, you may find that the set of principles of global governance constitute the theoretical approach of One Health governance to ensure that it is efficient, responsive, equitable, and inclusive, participatory, transparent, and cost-effective. For instance, as for good governance, it requires the emphasize the transparency and accountability, ensuring that the decision-making process are open and the decision makers are held accountable for their decisions. As for the rule of law and legality, based on the principle of rule of law and ensuring that all actors are in accordance with the law. So, similarity, One Health governance also have to operate within the legal framework to ensure the legitimacy of cross-sectoral cooperation and the implementation of policies. As for the policy integration and coordination, we can see that a good governance principle can promote coherence and coordination between different policies. It invites us to integrating between human, animal, and environmental health policies to ensure that policy objectives are mutually supportive. So let's move on to the One Health governance architecture. Here you can see that there are several stakeholders, scenarios, and partnerships that contribute to the One Health governance architecture. First is the multiple stakeholders of One Health governance. As you can see from this table, there are several types of stakeholders. For instance, the government sector, international organizations, non-government organizations, private sector, academic and research institutions, communities and citizens, as well as other stakeholders. As for the government sector, their roles may include implement the risk reduction measures, respond to zoonotic diseases, plan and coordinate. The examples can be the health sector, agriculture sector, environmental protection departments, or other educational departments. As for the international organizations, there can be lots of global and regional health and environmental affairs. The examples can be WHO, UNEP, as well as other regional organizations for health and the environment. As for NGOs, they can advocate for issues and provide professional support. The typical examples is the environment NGOs, public health NGOs, animal welfare NGOs, and academic groups, etc. As for the private sector, they may focus on policy implementation and continuity, may implement risk reduction measures to avoid production and economic losses. The examples may be the healthcare companies, food and agribusinesses, environmental services companies, consulting firms. As for the academic and research institutions, they can provide expertise for disease diagnosis, data analysis, and specialized technical activities. These examples can be universities, independent research institutes, or medical colleges. As for the communities and the citizens, they can promote community participation in policy and activity implementation. For instance, there are the community leaders, volunteers, general public, consumers. They are all kind of examples of this type. And other stakeholders may be the information dissemination, public education, financial support, or policy and law formulation, such kind of role. And these examples can be the median financing institutions, policymakers, such kind of this. So the next table is deals with the three scenarios applied with White House governance. Actually, we can have three levels of scenarios: global, regional, and national. As for the global level, we can see that its role is to consolidating White House surveillance through the international treaty. Funding of capacities should be prioritized, or strengthening environmental dimensions through regular reports and risk assessments. And the domains may be the global health security and disease surveillance, or the global environment and ecosystems protection. The activities can be coordination through mechanisms, international health response measures, or promoting food safety standards and nutrition policies, improving sustainability of food systems. The good examples can be the ongoing pandemic treaty or the global health network. As for the regional level, its role is to influencing White House implementation at a downstream level through trade standards or bonds, or incenting regional grouping countries to research and development and to mitigate risks. The domains can be disease surveillance and control, food safety, antimicrobial resistance management, or ecosystem protection. The activities can be establishing cross-border data sharing or early warning systems, sharing latest technologies for monitoring and controlling the plagues in food, or developing policies and sharing best practices for the rational use of antimicrobials, or managing impacts of human activities on wildlife habitats. The examples can be One Health Network Southeast Asia or the One Health Action Commission. As for the national level, we can see its role is on stronger institutionalized cooperation between government departments, transferring One Health approaches to government action. The domains can be national level or provisional level or the community level. Activities can include legislation and standard setting, or formulate specific prevention policies, share academic information or collaborative research or encourage community participation. As for the community analysis, there can be health education, disease prevention, waste management, livestock management, or local monitoring empowerment. The examples can be that as for the national level, there can be implement measures such as travel restrictions or establish MT composed of health, agriculture, or environmental department to jointly formulate epidemic response strategies. As for the provisional domains, they can be closed-leaf poultry markets, implement vaccination, or jointly carry out epidemiologic investigations or laboratory testing. As for the community analysis, there can be conduct lectures on disease prevention or promote safe drinking water, toilet facilities, or establish garbage collection or guide a scientific feeding method to reduce livestock infection risk. So the next picture is deal with the relevance of public and private partnerships in the One Health governance architecture. Actually, we can see from this picture that there are various types of public-private partnership. It can be public regulation that without involvement of private actors, or it can be some cooperation such as the consolidation and competition of private actors, or co-regulation of public and private actors, or delegation to provide actors, participation of public actors, or the public self-regulation in the shadow of hierarchy involvement of public actors. There can also be public adoption of private regulation, output control by public actors, or it can also be public self-regulation that without public involvement. So from this picture, you can see that there can be increasing autonomy of private actors or increasing autonomy of public actors. They all contribute to the public-private partnership in the One Health governance architecture. So let's move on to the practice cases of One Health governance. Here we introduce three typical cases of One Health governance. The first is the shared water sources in the Lake Chad Basin. The second one is the crisis of desert locust plague and COVID-19 in sub-Saharan Africa and Southwest Asia 2019 to 2020. The third case is a typical case of from China. It's about the China's microhydro technology contributes to sustainable development in Africa. So why I choose these cases? This because that such kind of cases exemplify the complexities of implementing One Health governance in different contexts and highlight the importance of collaborative efforts across sectors and regions. So let's have a closer look at the first case. As you can see from this picture indicates the changes of the Lake Chad. Actually, the Lake Chad has been surrounded by several countries. You can see from the map that there are Niger, Chad, Cameroon, etc. As you can see from the first picture that in 1963, the lake water is a huge place. However, it becomes smaller and smaller. And you can see in 2007, you can see that the water lake has been nearly missing, disappeared. So why there is such kind of challenges of the water problem, and how can we deal with such kind of challenge. So you can see this is a new project to improve such kind of water sources problems. There is established of the Lake Chad Basin Commission. This kind of commission aims to regulate and control the utilization of water and other natural sources in the basin, to initiate, promote, and coordinate natural sources development projects and research within the basin area, to examine complaints and to promote the settlement of disputes, thereby promoting regional cooperation. And it is worth noting about the legally binding water charter. This water charter is established in 2020. It aims to equitably address water management issues, establish rules for surrounding wetlands and fish populations, maintain water quality, prevent water-related disease and ecological hazards, coordinate monitoring, evaluation, and communication tools, and support civil society participation in the above objectives. Because it is have a legal binding force, so it can improve the implementation. Such kind of case indicates that an effective White House government requires the long-term institution requires long-term institutional approaches, legal and policy process, as well as regional actual networks. So let's move on to the second case. It is about the crisis of desert locust plague and COVID-19 in sub-Saharan Africa and Southwest Asia, 2019 to 2020. As we can see from this picture, there's kind of crisis of the plague. And this picture is also you can see from this picture that a man chases away a swarm of desert locust in several countries, Kenya. So it's a very much of a challenging or terrible issue. And also, this is another picture to show that it may have a lot of serious issues that will not do good to people's health and also to the environment. And this map also indicates about the situation of the desert locust infestation. And you can see that there are a lot of places has this kind of challenge, and there's also a lot of people. There indicates that 28.5 million people have such kind of challenges. So it also have to pay $231 million to deal with such kind of issue. And according to the document that published by the Food and Agriculture Organization of the United Nations, and you can see such kind of Great Horn of Africa and Yemen, the desert locust crisis appear. So there are a lot of the challenges has been awarded by such kind of international organizations. According to such kind of documents, the FAO's Commission for Controlling the Desert Locust in the Western Region and FAO's Sub-Regional Relations Team for West Africa and the Sahel are already working together with the potentially affected countries for the implementation of anticipatory actions such as training, pre-positioning of sources, initiating surveillance, activities and control operations. The countries of the sub-region most exposed to the threat of locust investigation are Basin Mosul, Chad, Mali, etc. All of these countries are already facing the COVID-19, so it presents significant further risks to the food security. So how to prove such kind of problem or how to deal with such kind of challenges? So we can see there are some kind of innovative measures has been implemented is to preserve the integrity of the food supply. The Pakistan government paid local farmers to collect locusts overnight and then make them into drinking feed. The project has been replicated by a private startup in Kenya. However, these initiatives remain small scale because they cannot rely on locusts collected from areas where pesticides has been used. National authorities do not have sufficient funds to compensate collectors. So this case indicates that the added challenges that requires the dedication of disease containment strategies as well as a long-term and global political commitment to deal with the root cause of outbreaks. Despite enhancing the early warning systems, actually, we have to improve funding capacities. In particular, creating incentives of capacity building should also be in priority. So let's quick move on to the third case. It's about China's microhydro technology contributes to the sustainable development in Africa. Actually, the microhydro technology can help counter the effects of soil erosion and desertification. It can also provide solutions for dealing with land degradation, better supporting food production and farmers' livelihoods in African countries. This picture indicates that the China microhydro technology Africa program leader who instructs treaties on such kind of mushroom production in Rwanda. And also there is a bumper harvest of microhydro plant mushrooms in South Africa. This picture shows that the livestock consuming microhydro food in a project in southern province Rwanda. So this case indicates the need for sustainable environment health interventions, providing direction for effective One Health governance. So our next question is about the ethics and ethical functions of One Health governance. Actually, there are three ethical functions. The first is addressing the challenge of inequality in One Health implementation. The second is guiding against imperialist attitudes. The final one is making stakeholders accountable. According to the guide to implementing the One Health Joint Plan of Action at a national level, there are three pathways. Pathway one is the governance policy, legislation, financing. The pathway two is the organizational and institutional development. The path three is about the data, evidence, information systems, and knowledge exchange. However, to implement a One Health approach at the national level from this kind of document or guidance, it implies that there is a need for advanced knowledge, including trained scientists, and appropriate scientific infrastructure. Second is economic resources for research and healthcare. Third one is the policymakers' willingness to adopt and approach and establish structural health policies. These elements can be challenging, especially for less developed countries, making it harder for them to implement costly policies with middle to long-term benefits. The second question is about guiding against impersonalized attitudes. As for warehouse implementation, actually we need to facilitating international cooperation and assistance. However, in reality, we should be aware that it cannot be undertaken extremely early, but should consider the traditions, beliefs, social practice, and customs of the populations concerned. To take the white market, for example, some countries, especially the less developed one, may face many competing interests such as hunger, malnutrition, food insecurity. They may be overly dependent on these protein sources to meet their food security needs. The third one is about making stakeholders accountable. According to the article, The Future of Zoonotic Risk Prediction, this paper indicates that without appropriate governance, the countries with the highest burden of zoonotic emergence might find their own data repacked in an analytic format may sold back to them at a premium by corporations from high-income countries. And another article, Gaps Between Research and Public Health Priorities in Low-Income Countries. Evidence from a systematic literature review focused on Cambodia. According to this article, it indicates another example in Cambodia. It indicates that research priorities may set by the granting agencies and laboratories from developed countries. It's based on the benefits they can have from publications in big journals or tackling scientifically important issues, but not on health priorities in developing countries. So in conclusion, we have revealed that good governance can ensure that a One Health approach is enforced and monitored. Besides, ethics provide moral guidance for these actions. And finally, the convergence of these two domains provide a solid foundation for building a more sustainable and healthy future. So this concludes my presentation. Thank you very much for your attention.
Thank you so much, Professor Zhu, for this insightful and rigorous reflection of the governance dimensions of the One Health, bringing theory, practice, and also ethics into the same conversation. It's very interesting. That is exactly the kind of integration that our field needs, really. So now our honorable speaker, the third speaker, is the environmental, who will bring us to the environmental drivers to this table. So Dr. Tribu Ambar Garjito from the BRIN, Indonesia, the National Research and Innovation Agency of Indonesia. You will present a land use change and deforestation, escalating vector-borne disease risk, and One Health solution. So, Dr. Garjito, please go ahead.
Thank you very much, Professor Isabenis, for the time. Good day, everyone. And today, in this morning and in this late afternoon in Indonesia, I'm going to present about the land use change and deforestation, the escalating vector-borne disease risk, and One Health solution. Yeah, I just maybe take some example from Southeast Asia, because of maybe a lot of problem regarding the land use change and deforestation that occur in the world. So I think we just take for the example here. So for the definition, I think all of us already know about the what is a land use change. according to the UNDRR in 2024, that land use change is human-driven transformation of land cover, for example, from the forest into the agriculture or plantation, or also infrastructure or urban settlement. While the deforestation, according to Moran and Lajouri in 2021, is a permanent removal of forests for other use, for example, logging, palm oil, mining, cattle, and settlement. This is a figure that we collect from, say, our country in Indonesia. This is the deforestation and then the land use change that's occur in especially in Sumatra and also in Kalimantan, and then from the forest to be in the plantation, especially for the oil palm and also for the some others commercial plantation. Yeah, sorry. Okay. This is the good illustration and good evidence what the global change in forest cover and will give the impact for the number of the vector-borne disease outbreak in the world. This data is collected from the world data, so from the 1990 and to 2026, and compiled by Moran and Lajouri in 2021. We can see here that in 1990, the forest cover is still very high, maybe more than 30.5% in many areas. The forest cover is still existing. However, after several decades, then the forest cover is dramatically. Maybe we can see here in 2016, this is only a view, less than 30.7% of forest cover disappear. And when we see about this palm oil here, it is opposite with the forest cover, because when the forest cover is decreased dramatically, the palm oil area is increase very fast in many areas, especially in some tropical country, for example in Southeast Asia, in Indonesia, in Malaysia, and then maybe in some country in Brazil or something like that. And for the vector-borne disease, due to the forest cover change to be a plantation or other land use change, so vector-borne outbreaks also increase. We can see here that the increase very dramatically, maybe more than 4 times or 5 times since 1990 until 2016. Here is about the what is deforestation and disease outbreak. So this is the relationship between the deforestation and disease outbreak. During a quarter of global forest loss is due to the conversion of forest to produce the commodity. For example, some other country, for example in Indonesia, in some other tropical countries, in South America, in some part of Africa, the commodities such as soy, palm oil, wood fiber, and it's increase very fast, and then the forest then disappears in many ways. So the significant association observed between the epidemic and deforestation, especially in country in the intertropical zone that retain extensive forest cover. For example, in Brazil, here we can see about this figure that Brazil, Peru, and Bolivia have a very fast deforestation in South America, while in Africa there are Congo and Cameroon that give contribution for the deforestation as well, and also in Indonesia and also Myanmar, Malaysia give contribution, especially in Southeast Asia part. More detail and more specifically, when we talk about the Indonesia, we can see the degradation of the forest very fast occur in period of 1990 until 2010. we can see here in around in 1919 and until the 2010, the forest is extend and change more than 50% than the previously. So I think it will give a very big impact, especially for the ecosystem and also for the potential of the vector-borne disease risk transmission in this part of the island. Similar with the Sumatra, in also part of Indonesia and also Malaysia, after the 4-decade forest persistent clearance and logging, there are only maybe less than 50% of the forest that's still present in this area. So that's why some re-emerging and emerging of the vector-borne disease occur in this part of area. So this is the general illustration when we see the land cover in many parts of Indonesia, from the Sumatra, Kalimantan, and then Java, Sulawesi, and also in Papua. The land cover is very fast change during maybe about more than 2 or 3 decades after that. Yeah. So what the effect or the impact of the rapid deforestation and land use change? I just take 2 examples here just to know about the evidence of this, the potential of the vector-borne disease risk, especially after the rapid deforestation and land use. So in some spots, especially in Southeast Asia, land use change, especially for deforestation and then forest fragmentation and also agriculture expansion, has altered ecosystem and increased human mosquito macaques interaction. And this situation highlighting the risk of the zoonotic malaria transmission. This is some area, especially in mostly in Indonesia and Malaysia, that have a forest loss during 2000 until 2009, and then published by Hansen et al. In 2013. So when we have land use change and deforestation, so some problem will appear, especially for the vector-borne disease. This is one of example. This is simian malaria, and then increase in some part. And for example, this is in Malaysia. The threat of simian malaria is emerging, and despite the zero of indigenous human malaria reported since 2018 by WHO in 2025, but when countries are reporting 100 or 1,000 of Plasmodium knowlesi cases, certification of malaria-free status should be postponed. So this is the upcoming problem, especially to achieve of the malaria certification in the country level due to the simian malaria. So, this is the WHO Western Pacific Region report in 2017 that explained how very high cases that reported in especially in Sabah and Sarawak and also in Peninsula of Malaysia about the simian malaria. So this is look like something that need to pay attention, not only in Malaysia but also in Indonesia, because of we have long-tailed macaque and also pig-tailed macaque that distribute in many area in both of the countries, and also the land use change also their behavior, especially the long-tailed macaque and also pig-tailed macaques. So beside the Plasmodium knowlesi, I think all of us is also know currently there are natural human infection with Plasmodium cynomolgi, Plasmodium innui, and other simian malaria parasite reported in Malaysia and recently also in Indonesia. So I think not only in the both country, but maybe in some other country that have similar epidemiological situations, such as maybe in the border of the Thailand and some other in maybe, for example, in Vietnam, and also in maybe some report in Andaman Island. So even though the cases in Malaysia is very high, but the report of the cases of simian malaria in Indonesia is still a few. So this is give the big question, especially in both of our country, Indonesia and Malaysia. Why in Indonesia the cases is not too high as similar as in Malaysia? Maybe due to the maybe some behavior of a population tribe in Indonesia that maybe in a border of Indonesia and Malaysia, they eat of many tribe, many that we call it diet tribe, eat macaques for the daily consumption. But in Malaysia, many people over there prohibited to eat macaque. So that's why maybe the population of the macaque in Indonesia, in the border especially, is reduced, and then in Malaysia is still high. So the other problem is maybe about the strengthening surveillance activities. In Malaysia, the surveillance are already working very well and routine. Maybe in Indonesia, the border, even though we have routine surveillance, but the capacity because of the wide area covered for the surveillance is very difficult. So the surveillance is not strong as in Malaysia. So this is the definition house of the simian malaria in especially in both of country when we especially for the long-tailed macaque and also pigtailed macaques. This is figure that I captured in North Kalimantan in Indonesia that I explain about the little bit deforestation, and then this is by a community, and then during maybe 10 years, maybe we can see about the very fantastic deforestation over there, and we can see about the land use change that give a very dramatically situation in this area. So when we get a situation with the deforestation, so it will be give impact for a long-tailed macaque, especially the behavior change after the deforestation. They will long-tailed macaque are primarily a forest dweller, so distributed in area with a forest cover, and then after deforestation, they tend to move closer to human settlement and agricultural landscape, and because of the loss of natural forest habitat and ranges of food availability, so they will go very close with the human, especially in the edge of the forest. So due to the habitat loss, the long-tailed macaque will be try to forage in crop, plantation, and urban area to find the food or diet. And according to the some study, previous study, after deforestation, change in group dynamic increase competition for limited resources and altered activity budgets occur. Increased time spent moving and exploiting anthropogenic food resources is also observed, and natural behavior like grooming may also adjust based on the stress of habitat constraint. So it also gives the very close impact to human interaction, because of they go very close with the human population, especially after the deforestation. They go in the edge of the forest, and then when they close the human settlement, so the potential of the transmission of simian malaria will be increased. So actually, this is a map that already published by MAIS in this is in 2021, if I'm not mistake, about the Macaca fascicularis distribution, and also Nemestrina, and also Irnania. This is a very important data that we can combine with the vector and also for the occurrence of the Plasmodium infection in human, to make sure about the risk of the transmission of the simian malaria in this area. So this is our recent in our publication in 2022 about the Plasmodium knowledge vector species, especially in Southeast Asia. So far, we have several Leptospirus, Anopheles Leptospirus group that has been identified as the important factor for the simian malaria, and then some others not Leptospirus group. There are Letivor and also Syndicus that also recorded in some country, for example in Andaman Island and also in Malaysia, about their role as the simian malaria vector. This is just recently a publication that published by our student from the James Cook that have been confirmed about the Anopheles dirus as the zoonotic malaria vector in Sumatra. And the other paper that also published during this year is about the Anopheles maculatus that confirmed positive with the Plasmodium knowlesi and also Plasmodium innui. This is also a similar student that have been finished his PhD now, and now is continue for his postdoctoral. And this is a situation of the breeding habitat for potential vector of simian malaria in North Kalimantan of Indonesia. What about the cynomology? So I think we need to pay attention of the Plasmodium cynomology because of currently in many cases already reported in Malaysia and in some part of Indonesia, and we just worry about the potential of the increasing of this transmission due to the availability of the environment and also the factor that already provide everywhere in a particular area where the transmission of the simian malaria occur. Well, I just talk about the one of example of the impact of the deforestation and also land use change for the potential of the increasing of the simian malaria. Now we just talk about the little bit different, if this is also vector-borne diseases that explain about the land use change as a solution of the schistosomiasis elimination in Indonesia. So just maybe brief presentation for this because of time is up for me. Maybe I just maybe a little bit explain about where is the situation of the schistosomiasis endemic area in Indonesia. This is the area where the schistosomiasis transmission occur in central Sulawesi of Indonesia. So actually the research and the implementation of the vector control program and also for the schistosomiasis control program have been conducted since 1914, and there are some steps that we have a very good progress to know, to understand the dynamic of transmission. We can the snail as the intermediate host was first discovered in 1971, and then in 1974 at least 13 mammalian species were detected and were known as the Schistosoma japonicum reservoir. And then in 1975 we tried for the mass drug administration using some approach, and we also using niridazole for the snail control. Even though the niridazole is very toxic, then we stop the implementation of niridazole for snail control, and then we continue for some schistosomiasis control activities. Even though we have a very fantastic working since many years ago, very hard working with the comprehensive activities. However, the cases is still high. And then after we have some comprehensive with the environment as the one of the important component, then the schistosomiasis elimination will be facing maybe hopefully in the near years. Actually, we have some schistosomiasis control and elimination program in Indonesia. We use routine and consistent surveillance, and then we also have routine treatment, snail control, provision latrine and clean water supply, sustainable health education, schistosomiasis control and treatment in animal, and also integration of all stakeholders. But this is one of land use change that give good impact for the interrupted of the transmission of the schistosomiasis. The intensification and extensification of rice field in the wetland give the contribution for the decreasing of the snail that have role as the intermediate host of the schistosomiasis in Indonesia. Intensification and extensification of coffee and also cacao plantation is also give contribution in the dryland and in the buffer area. Candle nut and nutmeg and also eucalyptus. This is also give the contribution for the decreasing of the snail habitat. So because of this evidence, so we are putting this approach for the environmental management by land use change in the part of the national strategic plan for schistosomiasis elimination program in Indonesia. So then we have integrated schistosomiasis control management, and we put environmental engineering to land revitalization, irrigation, and also support of fishery by land use change in this area. And also we invite the Ministry of Agriculture to make a livestock management, and also we invite the Ministry Agriculture and Local Government to reuse the abundant land to be a productive land for plantation and also for the paddy field. So based on this SAMS approach with the land use change, so actually in the particular area in the schistosomiasis endemic area, especially in the Napu highland and also in Lindu highland, the cases decrease very well. So that's why we continue to do this, even though now the budget is not always sustained similar with the previously, but we continue this approach, and hopefully we can achieve for the schistosomiasis elimination in Indonesia, hopefully in surrounding in 2030. This is the progress of the Oncomillenia hupensis linduensis. This is intermediate host of the schistosomiasis in Indonesia for the control of the snail, and the progress is very good so far. That's it, I think, for my presentation, and hopefully it's still covered in the exact time of my presentation. Thank you very much, Professor Isambenis. Yeah.
Thank you so much, Professor Cartito. Your presentation reminds us that One Health is not only about pathogen and hosts, it's also fundamentally about ecosystems and human land use. So we now move to the round table. I invite Professor Wee and Professor Zhu to reactivate their cam, and we can start by maybe I am waiting also from the attendee if they had any questions. I see that Professor Wee responded to one of the attendee questions about Python softwares. So now I will maybe start with a question to all of you. So my first question, it could be which of these dimensions in the most underestimated in current One Health policy in Asia in general, and what would you change in the next 5 years? What is the most feasible and easy things that could be targeted easily in Asia? So I remind that Professor Wee taught ecological surveillance and dynamic modeling. Professor Zhu taught about governance and ethics, and Professor Gargito taught about deforestation and species displacements. So what could be more generalizable and feasible in Asia countries? So who want to start? Maybe Professor Triwibo
Okay, thank you very much, Professor Isam, for the very good question, and I think this is excellent question. So yes, actually, even though we have some problem, yeah, we have facing problem, especially for the some zoonotic disease, particularly for vector-borne disease. Actually, not only vector-borne disease, but also some zoonotic disease in Southeast Asia. We have some difficulty actually for when we conducting some surveillance. For example, for the zoonotic malaria, particularly in Indonesia, we have cases mostly in area with very close with the forest, where the settlement is not too many, but many forest worker that infected with this disease. So we need to strengthening the surveillance, especially for the forest worker and also for the people that very close with the forest and very close with the area where the land use change and deforestation occur. And then we need to look like also to give the community participation for the people that live surrounding this area, and also we also need to strengthening the surveillance, especially for the human cases surveillance for the infection of the plasmodium, and also with the vector surveillance, and also the collaboration between the other sector, especially for the agriculture and forestry, to work together to make us look like prevention for the transmission of the disease. For example, maybe during the 5 years it's not easy because of we still have a problem regarding the diagnostic of the disease, because of we have some problem to make sure this is maybe for a simian malaria or not, because of the people and the diagnostic laboratory diagnostic is not similar, the situation and the quality. So we strengthening the laboratory capacity in every regional to strengthening, to cover and to give the information of the burden of disease in every zone. So hopefully when we get the burden of disease in every area, and we can calculate the potential of the transmission, and then we can of course to give a strategic plan in the central government together with the local government to work together to give the enough budget to work for the simian malaria control program. So this is maybe just a little bit maybe our suggestion, because of so far it's still need for some evident data, and also some strategic, especially for diagnostic, and also strategic for surveillance for in human and also in animal. Thank you.
Thank you so much, Professor Kajito. Professor Zhu or Professor Wee, could you participate if you want? Did you hear my question, or should I replay?
Thank you, Professor. Yeah, and it appears to me, just you mentioned about the question, how to improve the One House approach in Asia. I have the idea that because the policy or the legal issue can be a good way to improve that kind of issue. For instance, as for Asia, there are already the One House joint plan. And as for China, there are also a lot of law, such as the law in the environment law that has been modified, and there are a lot of health issues. And at the global level, we can see that the WHO has also there is a new treaty about the WHO pandemic agreement. So it will encourage a lot of countries improve the White House approach, and also it will also accelerate the enough funding, because as for some countries, especially some developing countries, they need a lot of the economic sources to improve the implementation. So that is my answer.
Thank you so much, Professor Wee. I didn't hear you. It's okay. I didn't hear you. Uh, Please, Professor Wee, we didn't hear you. Even if you check your audio process, please. Maybe in your computer. So maybe we will move to another question, waiting for Professor Wee reconnection. So I think one of the questions that I can start also to briefly, it's for Dr. Wee. For example, or let's go to Dr. Cargito, please. So, Dr. Cariju, your presentation showed a striking statistic. Vector-borne outbreaks have multiplied by 4 to 5 times since 1990, in parallel with the dramatic drop in forest cover. And your example of simian malaria in Malaysia and Indonesia is particularly powerful. So the WHO malaria-free certification of Malaysia is being postponed because of zoonotic Plasmodium knowlesi, I think. So transmitted by displaced macaque. So this is very alarming, but also it's very knowledgeable. And so you also pointed out of fascinating cultural epidemiological difference in Indonesia. Traditional tribal hunting reduce macaque populations, and while in Malaysia macaques are protected, so leading to higher zoonotic spillover, if I do not miss the words. So my question, if we cannot reverse deforestation in the short term, what realistic intermediate measure would you advocate to break this displaced macaque human transmission chain? So, and how transferable in your Indonesian experience, for example?
Excuse me, this is a question for the Dr. Yinlik or me. Hello?
Yes, Professor.
Yeah, this is question for Dr. Yinlik about modeling or for me?
Yeah, for you, because yeah, for macaque.
Yeah. This
you
is
talked about Indonesia and Malaysia and the spillover and what could be done now. This is really questionable.
Yeah. This is a good question. Actually, I'm actually really attention with your question. Yeah, actually, we have a very interesting situation when we talk about the macaque behavior, especially in Kalimantan, because of I have been conducted studying during maybe last 4 years in North Kalimantan in the forest area in the border of Indonesia Malaysia, and very difficult to get mosquito, especially for the Anopheles leucospores that have role as the simian malaria. But we found some simian malaria cases in the human. But during this period of time, very difficult to find the macaques. And then we asked to the people surrounding this area, and then they said that they eat macaque. So that's why there is no macaque everywhere in a very close with the settlement and also village. And then we just found maybe 1 hour when we go enter the forest. But in Malaysia, this is prohibited because of they have regulation to prohibit people to killing the macaque, especially when they did not look like disturb the human population. So that's why macaque in Sabah Sarawak in the border of Indonesia, in Malaysia, they have a lot of macaque over there. So that's why maybe the dynamic is different. So we finally we found, okay, maybe the cases in Indonesia is low due to the human behavior in the border, and then the Malaysia they have different behavior for this. So actually we have some approach for protecting the people in the area. For example, in Indonesia, when mostly of the people that infected with the simian malaria is maybe for example is forest worker. So we give some look like discussion and give some program for the local government to distribute, to identify what the group that working in the forest, especially maybe for the logger or maybe for the hunter, and then we give the approach to them, to their group, and then try to distribute, maybe for example impregnated treated hammocks or maybe impregnated treated bed net when they stay in the forest, in the jungle. So that's why it will be one of the solutions so far. And also maybe we just facing for the hopefully the some promising replant, for example spatial replant that hopefully it can give the good protection, especially then they stay in the maybe shelter or in hunt in the forest. They just put maybe some spatial repellent, and then they can protect from the mosquito biting. So so far we just did this, and of course we strengthening some health facilities, especially close with this area, to have a good identification for the simian malaria plasmodium. So when people getting fever and then they have a suspect as the plasmodium infection, then we can detect in the beginning in the health facility, and then when they get, for example, suspected plasmodium malaria because of plasmodium knowlesi, for example, is have a similar morphologically with the plasmodium falciparum in the early trophozoite. So then we suspected, and then they transfer to the regional lab for the further confirmation for the PCR assay. So that's why so far we have some plan for this, and we have a collaboration with the we just recently have meeting with Malaysia, maybe just 3 weeks ago. We have meeting in Kuala Lumpur, and we have beginning for the collaboration to strengthening our both country capacities for screening and for finding, and also hopefully for the controlling of this transmission of the simian malaria. Yeah. For the macaque, it's very difficult to change to change back their behavior because of the land is already changed, and it's need many years to change it back. But for the protection, for the prevention, yeah, we can use what maybe that we can feasible for conducted in this area. Yeah.
Perfect. Thank you so much for your intervention and explanation. It's very interesting and very good work and challenging also. I think Professor Wee now is able to answer and participate. We have also Professor Jean-Marc with us. If he want to intervene or ask or do any question or explanation or clarification, it's also welcome. It's also the case for the other attendees and panelists. So I will return back to Dr. Wee, if it's possible to answer the first question, or maybe I should give you another question. Professor Wee? Okay, let us move to Professor Zhu, if it's possible. Professor Zhu, your concluding warning was really interesting, because you said that without appropriate governance, the countries with the highest burden of zoonotic emergence might find their own data repackaged in an analytical format, sold back to them at a premium by corporations from high-income countries. For example, the Cambodia example that you presented showed that research priority are set by funders in developed country, not by local health needs. So in a multi-jurisdictional reality like the one we are living right now in this webinar, whose ethics framework should prevail when human, animal, and environmental priorities conflict across countries? So, did you have any thought or reflection about that? What could be the minimum ethical standards, I will say, that the countries, even in international scope, could decide to respect or to follow together?
Thank you, Professor, and thank you for your question. Yes, I really appreciate that you mentioned maybe there should be some standard to guide this issue. I actually noticed that there are such kind of guidelines that are designed by the World Health Organization. There are a lot of documents deal with the global health ethics, and it also indicates the key issues that we should be aware. So I think WHO has already do a lot of such kind of job. But as for the civil societies, we can also make such kind of similar or maybe much more specific standards or guidelines to improve such kind of issue. Thank you so much.
Thank you so much for your answer. It's a precise answer. Council is also too interested. So, Dr. Wee, if you are able now to answer this question, if not, we can move to another. So I will ask the question. Then, if you cannot answer, maybe you can write. But if not, it's not mattering. We can receive your answer after without any problem. So my question is linked to the SFTS, because you showed 84% of SFTS cases in Anhui were associated with just 3 outdoor activities. You precised farming, cross cutting, and tea picking. And your dynamic modeling found that R0 exceeded 1 in multiple cities between 2021 and 2023. So my question, with such a clear occupational and ecological signature, what prevents us today from moving from passive case reporting to systematic pre-season prevention targeting the specific worker population, for example? Is it any scientific obstacle or economic or governance related obstacles, or this is already managed and decided to follow? I don't know if you can discuss this question. If not, I will just send it after this webinar. Maybe we get your answer. So I think one of the questions that remained is also maybe I will ask Professor Cargito again for this time, and I will switch to the African perspective if there are any knowledge, common knowledge from Asia experience. So imagine a low resource country in Francophone Africa facing rapid deforestation, for example. What would be the minimum One Health surveillance package they should build today before the next emergence while keeping governance of their own data and what is the irreducible core, but especially what could be the right monitoring surveillance that we should do for such experience?
I think this is very interesting situation in Africa. I think because of when we have a fast deforestation. So for the first, I think we need to pay attention of the some particular cases in that area that may be unknown or maybe something that before the deforestation the cases is still low, but after deforestation there are some maybe some several times outbreaks, something like that. So when we found a situation like this, and then this is a correlation with the maybe when we need to after we get the data from the human, of course we need to find out for the what kind of the maybe reservoir or maybe the factor that have role also in this area, and is there any possible and for the receptivity of the maybe for factor or maybe for the animal that have role for the transmission. So we need to look like conducting surveillance in the animal and also in the factor for to continuing the data in the human, I think. So for the first, of course, the cases is the important thing to know. If there are no cases, I think it's okay. But if there are some cases that maybe it's look like strange, or maybe sometimes actually we have these cases in the previously, but still in the low cases. But after the deforestation very high, so of course the deforestation will give impact for this increasing of the cases on the outbreak. So after that, we will follow up with the some One Health approach with the human surveillance, animal surveillance, vector surveillance, and then of course environmental surveillance. And we can combine it, and also the local government should be involved in this situation. And of course, maybe if there are some companies that have role for the opening the forest, they also have responsibility to join with us and to support maybe some budget to find the situation of this, and then maybe to give some budget for by the region for the activities for the maybe for the local government and the Ministry of Health to work to get the detailed information and the dynamic of the transmission. And then after that, after we get the dynamic transmission of the disease, then we will follow up for the strategic plan to controlling this situation. I think that's it, maybe.
Thank you so much for your experience and advices. So we remain on time, and hopefully, and I thank you so much, Professor Wee, Professor Zhu, and Professor Cargito for these three deeply complementary presentations and this stimulating exchange. Thank you so much. From the ecological dynamics to the ethical foundation of One Health to the deforestation-driven emergence of zoonotic malaria in Indonesia and also Malaysia, you have given us a remarkable view of how human, animal, and environmental health are inseparable, I will say, and not inseparable. And many of the street, particularly the data sovereignty question raised by Professor Zhu, and the cross-regional surveillance gaps between Asia and Africa highlighted by you also, will resonate this afternoon when I will have the privilege for presenting in session 6 on building a Francophone African One Health Hub. I warmly invite you all to join us at 2 p.m. For the session 6. But we have between another section, a plenary section with Professor Raman Bidi that will start after exactly 30 minutes. So we will take a break, then we will continue with the same link on this main day 2 of this international webinar. Thank you so much for attending, and it's the session 5 is now officially closed.
Thank you very much,
so much.
Professor
Thank you.
Isam and others. Yeah.
Good afternoon, Professor Beatty.
Yeah, good afternoon. You've done really well. This conference is so well organized. Well done.
Thank you so much. So we are waiting for Professor Zhu, and I will prepare your presentation.
That'll be fine. And Isam, shall I just say next slide, please?
Yeah, of course.
Yeah, okay, sure.
Don't
Okay.
worry about it.
Yeah, thanks.
Okay.
Perfect,
Hello.
Professor. So I think Professor Zhu is not here, so maybe Professor Frutos, you will moderate this plenary keynote.
Thank you.
And we will start in 2 minutes if you want. So, as you like.
Seems to be something. Hello, can you hear me?
Perfectly.
I'm going to disconnect and reconnect again. There's something wrong with my connection.
We hear you, Professor Frutos. We hear you.
Okay. Can you hear me? Can you hear me?
Yes, I can hear you, Roger.
Okay, very good. Thank you. I had a problem with my previous connection, so it's okay. It's fine. Thank you.
Isam, do you want me to start?
Yes. Okay.
Okay.
So maybe we should start. Professor Raman PD, if Professor Roger Frutos is not here,
Yes, I am.
so you can start, Professor Roger, by introducing Professor Bedi, then he will give his talk. Thank you so much. So.
I think we can start. So, do you want me to introduce Professor Raman Bedi? Because I see Professor Zhu is not here, so I can do it to start the plenary session. So thank you all for participating to this plenary session, and thank you to Professor Bedi to give his keynote address, because you may not know it, but he's extremely busy and traveling a lot, because yesterday he could not attend the plenary session because he was on the plane. He was on a plane from China, and this afternoon is traveling again. So thank you very much, Professor Bedi, for finding the time to give this presentation. And Professor Bedi is also the very important person in this webinar, because he's also the president of WFPHA, the World Federation of Public Health Association. And so it's very important to have his view and his perspective on One Health and global public health, and what we could do in the future and what we should do to really implement this approach. So please, Professor Bedi, the floor is all yours.
Professor Frutos, thank you so much. And thank you everyone for inviting me. I am so sorry I couldn't join you yesterday, but I only landed back in London in the early hours this morning, and coming back from spending a week with Professor Zhu and his wonderful team in Shanghai. I also just want to say how impressed I've been over the last 2 years with the One Health Working Group. And what I'm going to say is in no way criticism, but a real encouragement and stimulus, I hope, for the group. But I want to make a challenge to all those involved in the One Health agenda. So good morning, good afternoon, and good evening, wherever you are across this extraordinary world of ours. I want to begin with a question, a genuinely uncomfortable one. When you hear the words One Health, what do you picture? Next slide, please. I suspect most of you picture the Venn diagram. 3 overlapping circles: human health, animal health, environmental health. You envisage researchers in laboratories comparing zoonotic overspill data, climate modelers projecting vector ranges from different emissions scenarios, or veterinary epidemiologists tracing a pathogen transmission across species boundaries. It's a compelling image and one used widely, and it has scientific vigor. It has institutional backing, the tripartite of WHO, FAO, and UNEP, all give it global legitimacy. And for understanding disease emergence or pandemic preparedness or antimicrobial resistance, it's genuinely important. But I want to suggest to you today that this image is comfortable, but it's become a cage. It confines us, and that cage has limits to what One Health can be and who it speaks to and what problems it can actually solve. Because here what I see when I look at the One Health agenda, I see a research framework dressed up in language of a movement. I see interdisciplinary science, impressive necessarily, and science that has not yet learnt to leave the seminar room. I see brilliantly researchers talking with other brilliant researchers, producing papers that cite other papers, attending congresses and webinars, and by the same communities year after year. And I see on the other side a very different chasm. Billions of people whose health is determined not by what happens in laboratories, but where they are born, what they believe, and who governs them, and whether anyone in power considers them as important. Next slide, please. My argument today is that One Health, to fulfill its promise, must become a social movement, not just a research program. And the discipline best placed to make that transformation is global public health. Let me be precise what I mean when I say One Health has fallen into a medical model trap. The medical model has many, as you know, is framing the health problems as primarily biological phenomenon. Requiring biological solutions. It locates a problem in the body, or in this case, across bodies, across species, across ecosystems, but it fundamentally looks at science and medicine as a primarily response. One Health, as currently practiced, has largely adopted this framework. One Health research question: how do pathogens move between animals, humans, and environments? This is an important question, but it's a question that privileges laboratory scientists, epidemiologists, and ecologists and veterinarians. It generates data, it produces models, it informs surveillance systems and biosecurity protocols. What does it naturally do? It doesn't engage with the farmers in Bangladesh who's making a land use decisions based on economic desperation. It does not naturally engage with a pastor in Nairobi whose congregation gathers 3 times a week and who's the most trusted voice in the community on any subject, including health. It does not naturally engage with a young climate scientist or activist in Sao Paulo who understands that human health and planetary health are inseparable. but who has never been invited to the One Health table. It does not engage with the human rights lawyer arguing for access to clean water as a fundamental right, not a public health intervention. These people are not peripheral to the One Health agenda. They are, in many respects, central to it. And yet the architects of One Health, its governance structures, its funding streams, its professional committees, consistently leave them out. Why? Because the medical model frames the problem as a technical problem. And a technical problem requires the technical experts. Everyone else, communities, civil society, faith groups, youth movements, human rights activists, are all best stakeholders to be engaged. A communication challenge to be managed, rather than a genuine partner in defining the problem and shaping the solution. This is not merely a philosophical objection, it's the practical consequences. One Health interventions designed without community ownership fail. Surveillance systems built without community trust engage incomplete data. Biosecurity measures imposed without cultural competence breeds resistance. Antimicrobial stewardship programs that deliver through clinical channels to communities who primarily access health through their faith networks reach only a fraction of those needed to reach. The research is good, the implementation gap is catastrophic. The closing that gap requires more than research. It requires a fundamentally different kind of institution and a different way of thinking. Next slide, please. Now let me make the affirmative case. Not just that One Health is currently failing, but I want to encourage you that this is what One Health could become. Social movements are at its core a shared identity of shared values, collective action towards a common goal. The most transformative health-related movements in history, the sanitation movements in the 19th century, the HIV/AIDS advocacy movements, the tobacco control movement, the environmental justice movement, succeeded not because of the quality of the evidence alone, but because they built coalitions. They mobilized people who were not previously seen themselves as health actors. They reframed technical problems into moral and political ones. They expanded the circle of those who felt implicated by the solution. So collectively, I would encourage you, let's reimagine One Health. One Health as a social movement would do exactly this. It would bring, by recognizing the diverse zoonotic disease emergence, antimicrobial resistance, climate health interactions, and ecological disruptions as fundamentally social, economic, and political in nature. They are driven by poverty, inequality, land tenure systems, agricultural incentives, trade patterns, and governance failures. They are not problems that will be solved alone in laboratories. They require political mobilization, community engagement, and a sustained pressure of a diverse civil society. Next slide, please. One Health as a social movement that would therefore deliberately and systematically expand its coalition. It would bring youth movements into the program because young people have both the longest stake in planetary health and increasingly the most powerful voice in public discourse. Movements such as Friday for Futures have demonstrated an extraordinary capacity to shift political attention. They're intuitive, connected with climate, diversity, and health, exactly the One Health framework. But in all my meetings, they are rarely even invited to the table. Human rights activists, because the right to health, the right to a healthy environment, the right to food and water, these are legal and moral frameworks that give One Health its teeth. environmental justice lawyers, indigenous populations, the land rights activists are fighting the same battles as the One Health scientists, but they're fighting from a different trench. Community-facing frontline, small farmers, community farmers, indigenous people, all have primarily interface with human systems and natural systems. Their knowledge, their tradition of ecological knowledge, local disease observations, community health understanding, and generally real concern about the human, animal, and environmental relationships. Engaging with these would be difficult, but at the moment we're rarely even engaged with them. And so I want to deliver in more detail one aspect, which is faith communities. Now, faith communities are the largest organized civil society sector on this planet, present in almost every community, in every continent, and trusted across generations, and almost entirely invisible from the One Health conversation. Next slide, please. Now I come to my central argument. Who can convene these broader groups together? Who has the skill base to bring together this diverse civil society orientation into a coalition? It is global public health. Because global public health thinks in populations, not in patients. It thinks outside the laboratory. Its public health orientation is inherently about conditions that produce health or disease across communities and societies. The social determinants, the structural drivers, and the policy environments. This is exactly the lens that One Health needs. Not how do we treat a disease, but what social, economic, and ecological conditions are generating this disease, and how can we bring about that change? The second, global public health, has at its heart a convening capacity. It can bring people together. It has a history of doing that. It is its core competency. The multi-sectoral partnerships across health and education, health and housing, health and transport, health and agriculture. This is bread and butter for global public health. Public health professionals are trained to work across sectors, to identify common interests, and to build coalitions that span institutional boundaries. This skill is precisely what One Health needs to bring about the change it needs to become a social movement. Thirdly, global public health sees everything through an equity lens. And this is perhaps the most important point I want to raise. The equity changes the One Health question entirely. It is not enough to ask, how do we prevent the next pandemic? We have to ask, who is the most vulnerable people that the next pandemic will impact? What structural inequalities determine differential exposure and differential harm? And how does our response address these entrenched inequalities? The One Health agenda, through equity lens, immediately expands the scope and asks very different questions and invites a response from the rural, the poor, the indigenous, and those who are suffering land inequalities. It connects One Health to human rights, to economic justice, to political participation, precisely the connection that turned research frameworks into social movements. The World Federation of Public Health Association brings together public health associations from over 100 countries. It navigates extraordinary diversity, cultural, political, linguistic, ideological. But it works together in a shared health goals. It's not trivial capacity. It's not trivial experience built over the decades. It is exactly the muscle that One Health needs to develop. The challenge I'm presenting to the One Health Working Group today is that skills are not there yet. The One Health committees are overwhelmingly populated by scientists. The convening competencies, the community engagement expertise, the facility skills, the knowledge of civil society, these are largely absent. Building a genuinely multi-sectorial One Health movement requires not just inviting new partners to the table, but developing new capabilities within the One Health community itself. I want to say at the very start of the One Health Working Group, I joined it because I think it is one of the most important working groups that we have at the World Federation. I've been so impressed with all the camaraderie, the way it works together, the way it actually challenges, produces high quality webinars, papers, and generally improves the thought leadership and the academic base. But I truly believe now the next phase for the One Health Working Group is to consider over time how it becomes a social movement. Who else needs to be included? What structural changes needs to happen? Next slide, please. Sorry, the next slide. This is. So this is just the framing of an equity lens. The challenges that need to be encountered. Next slide, please. Next slide. So I was just identifying. Okay. So let's meet the challenge that we need to do. We need to transform different structures, different skill gaps to be filled, and to invite a different debate in our next phase of the One Health Challenge. So let me close, next slide please, with an honest assessment of the challenge that we have. We have to redefine our boundaries, formally expand the governance structures, include groups, and to encourage them and to actually train them. Youth, faith communities, human rights, indigenous communities, not as people to be informed or educated, but as genuine stakeholders and as partners of the program. We need to build the public health bridge. The World Federation and national public health associations need to develop community engagements, and where they are taking place, the One Health Working Group needs to build upon it. Use the skills of the toolkits and the convening power that public health has. And then thirdly, let's view everything that we do through an equity impact assessment. And that's what we should encourage. Who bears the burdens? Who holds the knowledge? Who shapes the response? And these have to be the standard evaluation criteria. Moving forward as a social movement will require quite a lot of change, and it may not happen over the next 3 or 4 years, but it's a direction of travel which I hope you will embrace. And we've got to learn how to do this together, because the triad is not enough. The social movement is the goal, and public health is the bridge. Thank you very much.
Thank you very much, Professor Bailey, for this really inspiring presentation, and which will make also the heart of the white paper we are thinking of writing out of these 2 webinars. It's really the core of what should be in this white paper. So thank you again very much. I would like to know, and thank you again, because I know your schedule is very, very tight.
Right.
And so thank you for taking the time to deliver this presentation. And I don't know if anyone has questions for the Professor Bedi. in the panel or from the attendees? Yes, I see one question in the chat from Fabien Marchois. He's from University of Côte d'Azur in Nice, in France. First of all, I want to thank you. How can complex laboratory data be translated into levers for civic mobilization without compromising scientific rigor?
Yeah, it's a really good question. Thank you, Fabian, for that. In social movements, there are different partners with different skills that they have. We do not want to ask our scientists to tone down laboratory data or the science, the expertise that they have. But we also recognize that that is only part of the solution that needs to happen. So what I've been encouraging on the social movement, in a social movement, we see the solutions, the implementation of things that need to happen. And the scientists and the laboratory data is going to be really important for that, but it can't stop there. What I'm trying to encourage us to think about is the complex laboratory data translated into levers for civil mobilization do not end with a citation in a high impact journal. We have to begin to think about how we use that data and how we work with partners genuinely who see the world differently, and collectively we bring about that movement. We saw that in tobacco control. The science about the smoking and its impact only had certain actions. But when society came along and translated that into movements, into legal frameworks, we started to see real change in tobacco control. So I think what I'm trying to say, Fabian, to you is thank you for the question. We will all have different roles to play, and it will not. A social movement is not just giving people information, even more palatably, but it's actually beginning to understand that data and then seeing what others can contribute to it.
Oh, thank you very much. Actually, Professor Brady, if I may, I would like to ask you exactly the reverse question. How can we ensure, what process should we use to ensure that participative data coming from participative research follow scientific rigor?
Yes, that's essential. We must do that. There's no doubt about that. But where does some of that data come from? So one of the things that faith communities, let me take an example of faith communities. In the global south, the majority, and we're not quite sure where the figure is, but the majority of all healthcare is provided by faith communities.
Mm-hmm.
And they are generating data, implementing data. They are the custodians of the healthcare interface with society. But we see that almost invariably broken down in the global north. And where historically, centuries ago, that was not the case, it is becoming increasingly the case. And we see two groups of people that are becoming very polarized. Our health community in some sectors see that faith communities are only concerned about end-of-life care or reproductive rights. And so treat that with suspicion. And likewise, the faith communities feel totally isolated from the One Health or the health agenda. We need to bridge that gap. And so this is not an easy fix.
Mm-hmm. Yeah.
It's not an easy fix, but we can see that if we want to really implement the One Health agenda over a period of time, we've got to walk along this path and we've got to work out how to do that. And what I would say to the laboratory data scientists is that we have got to learn how to work in partnership and to translate the information together. And we have got to mobilize the skills that each one has to build in a social movement. A social movement is not just implementing information from one source. It's actually true participation.
Thank you very much. Is there any other question?
Yeah, I will continue to ask the same question
Please.
about faith communities. So, because it's too interesting. For example, in Morocco, in Francophone Africa, in Indonesia, where many of our speakers come from, faith community are central to public trust. So, what practical pathway do you see, Professor, for one health institution to build genuine partnership with faith communities beyond
Okay.
using them as a technical message and channel communication?
Okay. Well, unembarrassedly there is a book on faith communities and public health being published by Springer in the summer. Okay, and I'm really pleased that it was the interns that I've been supervising at the World Federation who have actually produced this book, and it gives solutions of how we can actually engage with faith communities and public health. But if you wanted let me give you an example, and I've written several articles in the Theological Press on this in England. We train people completely in parallel systems. Faith leaders are trained in a specific way, and public health people are trained in a curriculum, and they really interface with each other. So right at the heart and the start of their careers, they really engage together. And what we have to do is to find an interface where people who are faith leaders and those that are going to be public health and medical leaders, we need to begin some degree of engagement with them so that they begin to understand each one's complexity and the world that they live in. And then we can hope over a period of time that that trust and that relationship will be built. So I believe that in theological training and in public health training, there should be some interface.
Thank you so much, Professor.
Thank you. Thank you very much. Is there any other question to Professor Bedi? Because, well,
Okay.
no.
Okay.
If not, yes.
Let me just say thank you very much, and
I
wish
thank you. We thank you.
It's been lovely being part of it, even for a short period. So thank you.
Okay, so thank you very much. I think it's time to release Professor Bedi because I know he has to go to London, correct?
Yeah, I do.
So thank you again for taking the time to give this presentation. So we thank you. So thank you, Professor Bedi. Thank you all for your participation. We will continue this afternoon in Morocco and Europe, evening in in Asia and morning in America. We'll continue at 2 p.m. Moroccan time. Okay, thank you again, and I wish you a good lunch to all of you, or a good dinner in Asia.
Thank you.
Thank you very much, all of you. Thank you. Alors,
Good afternoon, Professor Roger.
hop là. Hello?
I think Professor Zhu is not connected. And also, I'm looking for Professor Kipping. Chan. I didn't see her. Yes.
Itham?
Yes.
I just got a message and I forwarded you the email from Dr. Chen, Shipping Chen. She said she cannot enter the webinar, so maybe a wrong link. I don't know.
She
I
cannot.
forwarded her email to you.
Okay.
Hungry?
Okay.
Very shipping.
Perfect.
Very pleased to see you. It works.
Hello, finally. Sorry. Okay. Sorry for that. It's something wrong with my computer. Sorry for that.
No problem at all. But I see Hongji was connected, but is no longer. Why?
I don't know, because maybe he is much more handsome. Maybe. Okay. Okay.
So we will restart recording, and
Okay.
we can start. I don't know if Professor Kurtos will just coordinate and moderate this final session, because Professor Zhu is not available right now.
It's up to you, Sam. I can moderate, but I'm speaking, so I can moderate, or you can.
We can exchange without
It's
any
up to you.
problem. It's okay.
I let you decide. If
So
you want me
please.
to moderate, I can, huh?
Yeah, thank
But
you so
otherwise,
much.
you do.
So do it, please, Professor.
Boom. Okay. Thank you very much, Sam. So, well, let's start this. Let me get the program. And you just need to open the program. Here it is. So welcome to this last session of this webinar. So it's plenary session, because we are addressing cross-cutting issues. So it's really a plenary session, not a specific one, even though we are going to address different topics like, but we will address AMR, we will address infectious disease, but they are all on a cross-cutting dimension, so multidisciplinary. That's why we have a specific session for that. So to start with, the first speaker in this session will be Dr. Shuping Chen from the University of Xiamen in China. And she's going to talk about artificial intelligence in the prediction and early warning of infectious disease. Sorry. So please, Shuping, the floor is yours.
Thank you. Thank you very much. Okay. How can we share my... Okay.
Okay, okay. We see it. It works. We can see your
Thank
slides.
you. Okay, thank you.
Thank you.
So thank you very much for this conference. At this part, I will talk about something like artificial intelligence in the prediction and early warning of the infectious disease. So here is the content we were talking about from the three parts of the slides of the section. First part is what we do in this part of content, and then how we use our research results to control the infectious disease, and then what we got from our results. So the first, what we do is actually is a combination of the mathematical models with the infectious disease and
also the combination with the theory, with the practice. So here, when we're talking about the infectious disease, so we must, the first thing is to know about the history of the infectious disease. So there are many parameters associated with the infectious disease, such as the latent period and incubation period, something like incidence rates, fatality rates, and also the exposure rates. It is all the parameters concerned with the natural history of infectious disease. First, we will find out the mechanism of the infectious disease, and then we will build models to simulate the transmission of the infectious disease. And so in the models, we can get the basic reproduction number and the effective reproduction number. So we can actually get the beta. We call it beta. It means the transmissibility of the infectious disease, and also the most important factor is the effective reproduction number, which means one case can infect how many healthy people into case. So two is very important for the infectious disease model. So based on the calculation, we can do something advices for the emergency infectious disease, and for the made some prediction for the outbreaks and pandemics, and also can evaluate the effect of different intervention measures. And on the daily surveillance, we can also make some suggestions for the major infectious disease, such as influenza or such COVID-19 or something like that. So this is the way we making our research, and this is the schedule of the whole things we do. And the first and most important thing, of course, is the control infectious disease. It can be by any way, by mathematical models or by evaluation reports, or something might be the intervention methods change to make some strategy for the government. And we use the models to do something like the cross-age transmission model. To make the cross transmission, we can calculate the transmissibility, and also we can see the vaccination effect by the models to calculate that. So based on our research, we also do some products by them. Finally, we can make the scientific research results into the practice use that will be helpful for the local CDC staff to carry out their work. So the products including something like platforms, or some calculators, or some tools to help them to draw a very beautiful curve online that all the products can make their work much to be more efficiency. So here is our work. Then we will go back to here, and I will choose the vector disease to show you how we collect these results, and how we collect this combine our work into the real production practice, real work. So first, it's dengue. So dengue fever is an important vector-borne infectious disease. Once we're talking about that, we firstly think the climate change is the most important factors can lead to the expansion of the habitat range of the vector species. So we do some research on that. Based on the past decade years, the suitable habitat area is changed, and we made some prediction to find out by the 2030 years, the suitable habitat area will be increased by 20% almost by compared to the 2019. And this results, this research is published, and this is what we want to know from the environment. Because when we were talking about the vector-borne disease, the environment is the most important things to thinking about that. So, and then we also think that the vector is also important. So we choose one of the 1,000 cities in China to make something prediction for the density of Aedes mosquito. So it can be predict for the in the future time, maybe 2 weeks, we can find out the density of mosquito is different, and we will take some control measures to reduce the density of the mosquito, which can efficiently reduce the incident rate of dengue. So here is some measures we can suggest the government to take to reduce the mosquito density. And also, based on our preview research, we can construct a dengue fever model. Here, we can construct a dengue fever model to assess the impact of mosquito-borne disease and to find out the transmission. And in the you can see the graphic on the left. You can see that once the intervention was taken, the cases will be gradually get down. So the cases will be gradually, and the trend will be down. And once the intervention was not taken, the cases will be much more higher, and there will be much more cases will be found if the intervention was not taken. So we can to make some assess of the intervention efficiency. The intervention once taken, it will be significantly reduce the case number. So, and then we also established a scenario of the dengue fever transmission between the factory and the local communities. So, what we got from this research, we can find out in different part of in different group of population, we can take different intervention strategy. So, so here is the different scenario to depend on the different prevention. And this is the two research results of our research on the dengue space and the intervention simulation assess the iPad, access the iPad. And also, we also think about in the different cities, the mosquito can fly anywhere. It can affect the area nearby the most outbreak area. So it can fly here to there. So they can there is a cross regional transmission maybe happened in the certain areas. So we also do some research to find out the cross regional transmission in the south of China, in the city of South China. So we found out, and also we make some models by that. When we found out, once the transmission was cut off, it will significantly decrease the others outbreak cases report, or even become zero. So cut down the transmission is the most important way we can find to different cities. And also, once the mosquito density was controlled, it also can significantly decrease the number reported, the infectious cases number report. So the two most efficiency intervention methods can be carried out in the cross regions. So here we think about that all the factors can be thinking or be taken into the consideration of dengue, and we still want to know, is there any other risk factors for dengue? So we do some research on the analysis for the major risk factors for dengue transmission. And we choose the south of the one city in the southeast of China, and we found out the most important risk factors for dengue is the mosquito residence index. It can be significantly impact the local transmission, and also the other risk factors, the brittle index, can also affect the local transmission. So it can be give some advices for the government to reduce the mosquito resistance, or to reduce the positive test to reduce the mosquitoes density. Then the dengue will be cut down the transmission very significantly. And based all our result for dengue fever, we can get a global surveillance of dengue to watch what happened in the global countries, the dengue, how it comes, and where is the severe country. We can find out you can see in the left map. The data is from the public open data reported on the online, and so we collected this data to make some surveillance platform for the dengue fever, and it's the real-time platform, and
Professor Roger?
Oh, what happens? We got interrupted.
Yeah, I don't know.
Oh,
But
let me try to contact Shuping by
okay.
WeChat. I contact her. I come back to you. We have a technical problem here.
Sorry.
Okay, she's back.
About that. I don't know. We're
I
talking
don't know.
about.
We got that doesn't matter. You're back. It's fine.
Okay, thank you.
Thank you.
So, what the last slide? What's the last slide here? When we talking, which slide? When we got from this one?
I don't remember. Try to go back maybe after.
After, okay. This one? Okay.
So go back one back.
Okay, here. This one, okay.
Okay.
So,
Start from
thank
here.
you. Sorry for
Thank
that. So we also do some analysis for the risk factors for the dengue, and we found out we choose one city in the south of the China, and also made some modeling to do some prediction, and find out the most important risk factors for dengue is determined by the mosquito resistance index, and when it can significantly impact the local transmission, and also the Pareto index can also affect the local transmission of dengue. So here is the other factors we also want to thinking about take in considering to the dengue transmission. And so based on all the research results, we want to note, we just sitting in a face to the computer, we want to note how the global dengue fever like today. So we put all our research together into the global surveillance platform for the dengue fever. So just like the left map, you can see in the left graphic. It can be seen in the real-time outbreak numbers on the global on every countries, which is high and which is low. We also can find the high risk area. Where is the high risk areas such as here?
This time communication got not lost but frozen. So hopefully it will be back.
Back to here. The next we want to talk is the chikungunya fever. Just like dengue fever, chikungunya fever is also the vector-borne disease. So we also want to.
Well, connection with China is not working very well. Oh, here she is. She's back. Hello, Shipping.
Sorry.
What happened again? Yes,
You
here.
like to be joking to us, the internet. Okay. So, well, back to here. So we also do some research on the chikungunya fever. We want to know how it transmit from the mosquito to human. So we built a mosquito-human cross-species transmission dynamics models. This is the unique models because it take the mosquito larvae Aedes adult mosquito into the consideration. So here the two group, one is the mosquito and the other is the human. It can be some cross, in fact, by the in the transmission. So in this model, we can also calculate the transmissibility and reproduction number. Here is the result. We can see that outbreak overall basic reproduction number is more than 7, which means one case can effectively make more than 7 people to be infected by this viral. So, but the human to mosquito is much higher. So we can, this is to make some the transmissibility into the real number, so we can see how severe it can be carried out by the transmission. This is the first time to establish a cross-species transmission dynamic models of the chikungunya fever in China. So we can use that. Well, we used that in the last year. Everyone, maybe the last year in China, there had some outbreaks of chikungunya in the south of the China. So during that outbreaks, we make some optimal. We made some suggestion for the government. So here, the first one is but by this model we can find out once the adult mosquitoes to be disinfected, they can effectively reduce the case number. So, and once we make the two combination between mosquito control and reducing mosquito bites, it significantly cut down the transmission to make the cases report to be reduced, the cases report. So that's simulation results have assisted the national CDC and the provincial CDC to take the exactly prevention and measures. And they can change the strategies for different areas and different peoples. So the most important thing is to reduce the mosquito. This is to observe by the last year outbreak. It is most efficiency rate. And also, based on our result, we also built some chikungunya fever platform. This on the left side, we can make some parameters adjustment settings, including some population or some other factors can be taken into consideration. And on the right side, it is the curve trend of the chikungunya fever. The red line is the new cases, and these two, it makes some invention take, and you can see one intervention method was taken, the cases will be decreased. So here is the way we can make some assess report for the government to tell them how their intervention can be taken into the most way for the outbreaks. Here is the chikungunya fever. So we according to the vector disease, we analyze all the risk factors for the disease, all the mechanism for the disease, and then there have a lot of results, but in the local CDC staff whom needs the results most quickly, fastly, and then they can do something right away to control the disease. How they can do that? So we think about the computer, the artificial intelligence. The AI can make people do their work much more quickly and fastly and make the right intervention method. So we use the computer language to make some early warning and risk assessment application. The left side is mosquito-borne disease transmission potential index. We call it P index. It's just like the prediction of the mosquito modeling. It can just like the forecast of the weather. So it can tell the government in the future 1 or 2 weeks which area can be most can be take most consideration to take the intervention method to control the disease, which is the hot pot, which is the core hot type pot.
I'm afraid the connection is gone again.
Sorry.
It's okay.
Okay.
The video is frozen, but we can hear you. If you stop your video, just show the slide, maybe the signal might be better.
So what about this? Can you hear me?
It's okay. It works.
Okay, sorry. Okay,
we,
so
we need to move to go ahead, shipping. Go ahead. Just
go
a matter
ahead.
of
Okay.
time. How many slides do you still have?
Oh, no, not many. So,
Go ahead.
so
Go ahead.
okay, sorry. So, we also made some platform and tools into the applications to help government for their real work. And this is our system. All make a collection of our results and to do some prediction and early warning and simulation. So we also put the dengue fever and the chikungunya fever system into the iPad, which is easy to carry and most convenient and fast way for their work because it is offline system. The data will be safe. And here is the platform for the iPad. And so the CDC staff can carry the iPad to their if their outbreak places. They can put some parameters into the iPad and see the curve change and make some decision for that. That will be very fast and helpful for them. So thank you for all your attention and sorry for the bad international. Sorry. That's all. Thank you.
Thank you very much, Shuping. Thank you. Don't worry. It's okay. You've been able to go through even with the technical problems. So thank you very much. Thank you. It's a very, very good presentation. Extremely interesting presentation. So we will, if you can stay, can you stay until the end of the session? Because I know it's late in China already. Otherwise, we can ask because other people are not in the same time zone as you. So it's very late in China now. So maybe we can ask you the questions instead of waiting for the end right now, so that maybe you don't have to wait until very, very late. So, is there any question to shipping to Dr. Chen? I saw a comment from Sandra Perez. Thank you so much, Shipping, for this very interesting presentation, despite the connection issues. Yes. This kind of platform is essential to be able to compare different places. Absolutely. Maybe, Sandra, if you want to ask more questions, or if anybody else wants to ask more questions to Shipping, to Dr. Chen, please go ahead. Oula, don't hear. Hello?
So I promoted Professor Shirley Srood and Professor Sandra as a panelist so they can interact directly.
Thank you, Dr. Benes and Dr. Furteau, and thank you for that nice presentation, Dr. Chen. I want to ask a question that's kind of out in left field because we're talking about control of mosquitoes, and that's so important to manage these diseases. I don't know what the controls are there in China. I'm imagining that you're spraying and trying to help people not leave water standing around. But I have a philosophical question for us to think about briefly, if we can. If we kill all the mosquitoes with DDT or whatever we're using, what are the bats going to eat? So, we're so interconnected and we so much need the bats. The reason I mention it is yesterday, Dr. Wakamoto mentioned a system in Brazil where they have introduced Wolbachia into mosquitoes and released those mosquitoes. And it doesn't kill the mosquitoes, but it blocks their ability to transmit dengue. And I have no idea if that's true for chikungunya or any of the other mosquito-borne diseases, but I just wonder if this group has any thoughts on that particular concern.
Okay, so in China,
Told you it was out in left field.
thank you for your questions. Thank you. And in China, maybe the government will the government there is a complex system for the Chinese government to control the vector-borne disease because it includes different kinds of departments, such as the CDC, which is the majorly take response to the take a responsibility for the human and also have the environment department who can help to make the environment to be much more cleaner to make the container of the mosquito to be take over or to help to make the disinfect to kill the mosquito. Kill the mosquito to help to also have some stuff to tell the people the knowledge about the dengue and help the government to make a clean environment. That's the different department, but they can call once it outbreak, such as in south of the China, every year there will be dengue fever cases reported. So once on that time, the government with and the different and all the related department will go out to take some measures to break down all the transmission way for the dengue fever. So I think it is most focused on the mosquito. Yeah. It is the department's responsibility for the public health, maybe public health, they can come together to do that. So once the outbreak is, once the dengue fever outbreak is occurred, sorry. Oh, sorry. Once the dengue fever outbreak is occurred, everyone in the related department will come together to go there, including the national CDC or the local CDC or the other department. Although they come together to focus to make all the best effort to control the dengue fever. So. So
Right.
we
I think it's
can,
just we're going to have to think about these things from multiple directions with many, many disciplines and it's not just China, we're all struggling. And I thought it was very interesting that Brazil has been able to come up with this Wolbachia system that I'd like to learn more about. So we all need to think about this. Thank you.
Thank you.
Chair, if I may, I can say something about Wolbachia.
Yes, thank you.
I just would like to say that with Wolbachia is not a mosquito control approach, it's a virus control approach. We need the mosquitoes to remain, we need the mosquito to reproduce, and we need the population to establish. Okay? So it's not at all a mosquito control. Huh? So there are several issues with Wolbachia. The first one is that Wolbachia works only on Aedes aegypti, not on Albopictus, because Albopictus already carries Wolbachia naturally.
Oh.
So you cannot put artificially Wolbachia, there is already one population, whereas there is no, at least on most population of Aegypti, also some Aegypti have some Wolbachia. The most frequent Egyptile population don't carry Wolbachia. So you can engineer them to insert Wolbachia. Okay, so it works only on Egypti. So the first consequence is that it doesn't work when you have the combination of both species, Albopictus and Egypti. Because maybe it's okay on Egypti, but then you have Albopictus which takes over. When you take care of public enemy number one is number two, which becomes number one. So that's the first issue. Second issue is that is population dependent. As I say, it's a lab population you put in the wild, and you try to favor the reproduction of this population, because with Wolbachia you have a reproductive incompatibility. Okay, and we know this happens. If you have a replacement of mosquito population, and it happens quite frequently. If you have a replacement of mosquito population, everything is wiped out. It could be a big problem. The third issue, as I said, the population must be present, must remain. Okay, so it is totally incompatible with any means of mosquito control. Because if you have Wolbachia, you cannot control mosquitoes, otherwise you're going to kill the population you introduced. So it means that you can control no mosquito. Because maybe you want to preserve your Aedes aegypti, okay, fine, but then you cannot control mosquitoes, so you're gonna have trouble with other mosquitoes like Anopheles or Culex or etc. Because you cannot use any means of controlling mosquitoes. It's incompatible. And that these are the really big issues with Wolbachia. Has been tested many places. Truly the only place I know where it's working very well, at least for the moment, is in New Caledonia. So in the Pacific, east of Australia, because in New Caledonia there is only Aedes aegypti. There is no other species. So it's no problem. But if, with bad luck, Albopictus comes in, then it will be a big problem. That's exactly the problem they experience in Brazil. I don't know if Mayumi mentioned that yesterday, but in Brazil, there was only, and the same in the Caribbean, there was only Aedes aegypti. So it's okay. But now, in several places in Brazil, Aedes albopictus has established. And Albopictus is very invasive. So if Albopictus takes over, maybe it will not be possible to continue using Wolbachia. So you see, it's it's good. But there are several issues. That's why I follow up completely on what Shuping just said. That's why our strategy is try to develop something which is population or species independent. So that whatever the population, whatever the species, it will work. And it's mostly at the control and the management, not control, but management at the community level. The human community, I mean. So it's mostly at this level that we try to do something, because then we have something that is completely independent from the population. Whatever species comes, etc., it doesn't matter. And when we look at what happened worldwide, in the future, sooner or later, we will have the blend of both species, Albopictus and Aegypti.
Wow, thank you so much, Dr. Furtos.
Sorry,
Very
sorry
informative.
for interrupting. And
We've gotten ourselves totally off schedule here now, but thank you for that very insightful discussion. I guess what I'm still concerned about is if we're doing mosquito control by killing the mosquitoes, what does that do to the ecological balance? And so my whole reason for bringing it up is that I hope that we're looking for ways to manage these things without totally destroying the ecological balance. And that's a big, big ask. So, but that's very, very informative, your comments about Wolbachia, because I didn't know all that. Thank you very much.
I would say don't worry, because mosquito control per se doesn't really work. We need to find something else, and management is better. That's why the kind of tool developed by Shopping is very important.
Great, thank you. I'm sorry to slow us down here.
Tweet of mosquito.
Thank you, thank you.
Sorry for the.
Oh, there's another question that just came in.
Yes.
What exactly is the purpose?
What is exactly the purpose of the portable simulation terminal? That's a question on the chat. Shipping?
The purpose for the portable simulation terminal, it can because in the CDC government, CDC staff, they will be go out to take any outbreak. When the outbreak occurred, they will go out immediately. But during the outbreak place, they must to do something right away and to find out when we take one intervention method, how it comes to reduce, if the cases report will be reduced or will be increased, how the effect when we got from the intervention method. So the portable simulation terminal carry out is just easy to carry it, and no need to the international, no need the Wi-Fi. It is offline. When some people, when the CDC government staff input some needed parameters such as the population, in the report cases, they can gradually show the trend of the outbreaks come, so they can decide which method they can use. So it is useful for the CDC to adjust their strategies for the outbreak.
Thank you very much, Shipping. So I don't know if there is any other question. Otherwise, we can move to the second presentation of this session. So thank you again, Shipping. Thank you very much.
Thank you.
That was
Thank
a
you,
fantastic
Roger.
presentation.
Thank you. And thank you for all your attention.
So then I suggest we move to the next presentation. The next presentation will be given by our host, our excellent host, who did a fantastic job in hosting this meeting, by Professor Issam Benis, who is going to talk about building a Francophone African One Health Hub, evidence gaps, and the experience of One Health Africa. So please, Issam, the floor is yours.
Thank you so much. So thank you, Professor Furtos, for moderating this final session. Distinguished colleague, dear participant, what we have witnessed over this past 2 days is a small experiment. 24 speakers, 13 countries, 3 continents, 4 parallel platforms. A simple question emerged: what would it could take to do this routinely, sustainably, and respectively across region, languages, and legal systems. This is what I would like to share with you today. I will speak about the hub we are building for Francophone Africa, but my real purpose is border. I want to use this hub as a starting point to discuss the most pressing question facing international scientific cooperation. Today, the question is, how do we share webinars, research, and knowledge across countries while fully respecting the sovereignty of each country and its data protection regulations? So let me start with a paradox. Francophone Africa carry a heavy burden of zoonosis, antimicrobial resistance, climate-sensitive diseases, and yet Francophone Africa remain peripheral to existing One Health regional networks. The major network, AfroHool, for example, in East and Southern Africa, SACITS in Southern Africa, AfriCONE as a research consortium, do remarkable work, and they exist from years before, but they operate predominantly in English and not really in French. The problem is not absence of expertise, and also it's not the language barrier. We have brilliant researcher, clinician, veterinarian, and public health professional, and professional that are fun and want to study on One Health science exactly. The problem is absence of connectivity infrastructure. Where is this infrastructure that help us to connect together with the same sovereignty? Linguistic exclusion translation, for example, can be a barrier into development, and also it could be a motive of exclusion, for example. So a question, this is what could be explained, what kind of platform could fill this gap without competing with existing networks and without being captured by any single institution or government. So this is another question that we should discuss, and I will return back by showing you just quickly the platform that you know. And as you see here, for example, it's segmented in many parts. So this is the most important point of this platform belongs to belongs to no one. I can see that. It's managed by its adhering member. It's independent of any single institution. It's inspired by the activity of the One Health Working Group of the World Federation of Public Health Association, but operates with full editorial autonomy. It does not replace existing networks. It builds bridges between them. And this is why neutrality is not absence of identity. Of course, we have all of us our own identity, but neutrality that we are looking for is the deliberate choice to host conversation no single institution can host alone. So I know that you know exactly how to reach this platform. So As you see, this platform federates a number of these institutions across multiple African countries, but also international partner. And as you see, this partner become more and more important in networking. So, and maybe the others will come and build more activities within this platform. That is the hopefully issue in the next months. So let me now be honest about what works and what doesn't right now. Linguistics and coding in French enable real participation from countries that were systematically excluded. Multifunction design serves real institutional needs, but they cannot have the possibility to share and to discuss without a real translation in live. So this is something that could be an obstacle. What doesn't work also is the funding sustainability is still institutionally dependent. Digital infrastructure remains heterogeneous across member countries, and South-to-South partnership are still less developed than North-South partnership. And mutual recognition of diploma also across borders remain a challenge. So we are halfway. The architecture is in place. The harder work, sustainability, equity, recognition is just beginning. So this is why I come now to the main question. Building a regional hub answers part of the question, but organizing this very webinar over the past 2 days, for example, has forced us to confront a much larger question, a question that no regional hub alone can answer. The question is, as you see, how can we share webinars, research, and knowledge between country, sustainability, and equitably, while fully respecting the sovereignty of each country and its data protection regulation. This is not an academic question. This is an operational problem. We just leave it for the past this 48 hours, I can say. So let me give you the figure. 24 speakers, as I said, and 4 simulators both platform. And now here is what most organizations never see. This is webinar makes simultaneously applicable at least 10 different data protection regimes. And this is the problem. We have to respect all the data regime, but also regulation. And for example, in Morocco, we have the law 0908, the European GDPR, the Switzerland revised NLPD, the China's Personal Information Protection Law, Brazil's LGPD also, Indonesia UUPD from 2022, I think. India has also DPDP Act and it's the American HIPAA also and CCPA framework. The Emirates Data Protection Law and Canada also they had this PPDA. So this 4 category of data processor, the hosting institution, the Zoom Incorporation headquarters in the United States, for example, the Google through YouTube and the partner institutions. So behind every international scientific event, there is a hidden web of legal regimes that no organizer fully masters. So what could be the 6 tensions? I think the first one, it could be the contrarian scientific consent. A speaker invited as a panelist cannot in practice refuse public diffusion without renouncing the invitation itself. The consent is formally collected, but structurally constrained. How do we juridically qualify this pseudo-free consent. This is the first tension. The second one, this contractual asymmetry. That means what? No academic institution can negotiate the term with Zoom or YouTube. We accept by default rules drawn under foreign jurisdiction. The tension number 3, invisible infrastructural AI. We can disable AI companion like we did, but we cannot disable recommendation algorithms, automated moderation, audio quality analysis, or platform analytics. The frontier between explicit AI and infrastructural AI become blurred. So the 4 tensions, this is the inevitable transfers. Every email I send to a Chinese panelist transfer foreign servers. Every file shared via Zoom transit on non-Moroccan cloud infrastructure. The legal notion of international transfer is overtaken by the reality of the technology. So we are not looking for local or country, regional autonomy, but we should think outside of this context. So what is the 5th tension? Parallel data retention. You can see that retaining registration data for 12 months as I provided in the consent. But Google, for example, or Zoom retain log independently. This parallel retention is tied to the official data controller. So we cannot erase it or discard it, even if we want. The 6th one is the right to erase and clear. So who can, for example, decline the participant or ask for deleting the entire video that he has participated on. So this is practically and operationally not working and doesn't exist. This 6 tensions are universal. There are a spoken problem of every international scientific community in the area of this AI and global platforms. So I qualified this as sovereignty without isolation. That means two extreme positions are tempting but are unworkable. Centralized data infrastructure, one cloud, one rule for all is politically unviable. And total fragmentation on the other side, each country, it's a silo, is operationally impossible. So science is by nature international. Pandemic do not respect data localization rules. And the One Health concept is also not respecting this silo work. So a third part is needed. And this third part, sovereignty without isolation, require, I think, 4 things. The first, each country, for example, define its own rules, not negotiable. National authority are legitimate. But the second, these rules must be designed to be interoperable, not identical. We are not asking for harmonization. We are asking for protocol that allow different rules to communicate. So the third is that trust mechanism that could be available and operational, which must replace forced harmonization. For example, mutual recognition between authority, certification systems, common reference frameworks, it could be a solution. And fourthly, the researcher remains in control of where their contribution circulates, not the platform, not the host institution alone, the individual as scientist. So respecting sovereignty does not mean accepting fragmentation. It means designing for interoperability. And this is the thing that is discussed also when we discuss AI platform, etc. So this is the future, the near future that we should also pay attention to it. So I will now just say some alternative, specifically 5 alternatives that could maybe invitation to discussion with the panel discussion. The first alternative is the multi-platform mirroring. A single event broadcast simultaneously on Zoom, in Bilibili in China, in a regional platform elsewhere, each operated under its own jurisdictions. It could be the best strategy. Speakers grant rights once. Platform operate independently. We are testing exactly this today with our Chinese delegation and with the support of China's, for example, in compliance with Chinese regulation, for example. So they can access with Zoom, but for the others, we can access by the YouTube. And we can move together to think to something that will work better for everywhere in the world. So even when we are starting talking about international webinar, it could be with a general feasibility, a technical operation with respectful rule and jurisdiction everywhere. The second alternative, co-owned regional hub as really nodes. So One Health Africa really for relays for Africa, but it could be also a hub in Asia, a hub in Latin America, in the Mediterranean. Each hub respects its own national authority, languages, etc. So the hub federates without merging. They become bridges, not silos. And the third one is structured graduated consent, with distinctive levels. For example, live participation with limited rights, public diffusion with broad rights, training reuse with restricted rights, or for example, AI training with explicit operational in each speaker choose at registration. So with this characteristic that could be implemented more in the different platform that we use to interact in online, could help to respect more any of the regulation in any countries. For example, for the fourth alternative, it could be the mutual recognition between data protection authority, a protocol where for an academic scientific event could be easily developed and it could be bridged and recognized by each authority within the United Nations or something like that. So for the host country, for example, is recognized by the partner authority like academic diploma recognition. We could imagine that the Moroccan CNDP, the European EDPB, the Chinese PEPC, the Brazilian ANDPD agreeing on a common minimum framework for that scientific event like that. So, and finally, for the alternative final point is the public registry of cross-border scientific event. A neutral multi-stakeholder registry where institutions declare their intention events, the platform used, the AI features activated, the retention duration, transparency replace ad hoc opacity. So if we have this information before, we can more and more adhere and be accessible and to use such platforms. These 5 alternatives are not exclusive at all. They can be combined. They can also evolve and evaluate but they are concreted starting points for a conversation that must happen now or in the future. So let me finish by asking, why does this matter globally? The next 5 years will see fragmentation of the scientific internet along directional lines, increasing regulatory divergence, growing reluctance of researchers to engage in cross-border collaboration because the legal cost is too high. One Health Africa propose counter models. So a neutral platform whose only mission is to make collaboration possible, sustainable, and respectful across continents, languages, and legal systems. This is what we are proposing. So this webinar, what you have just experienced it for these 2 days, it's itself the experiment. If we can do it once, we can design the framework that make it routine. Africa is not asking for permission. Asia is not asking for permission. Europe is not asking for permission. Americas is not asking for permission. We are offering the host the conversation, and I think that my last word, it could be thank you for your attention, and the floor returned back to Professor Frutos for discussion, if there are any. Thank you.
Thank you very much, Professor Benes. Thank you very much. And you're definitely right. Africa is not enough put forward. Absolutely. So what I suggest, because we are now all in the more or less in the same time zone, is to move to the other talks and have a general discussion at the end, before your concluding remark.
You're welcome.
Thank you. So I would suggest we move now to the next speaker in this session, who is the Professor Jean-Marc Rollin from IHU Méditerranée Infection in Marseille, in France. And it goes very well with what Issam said, because going to talk about AMR, but also Mediterranean initiative, and of course involving a lot Africa. So his talk is titled Medica2C, an innovative Mediterranean initiative to tackle antimicrobial resistance in the context of One Health. So please, Jean-Marc, the floor is yours.
Yeah, thank you, Roger. Did you see my slides?
Yes, absolutely.
Yeah, they are in the front screen. Everything is okay.
So it works very well. So please.
So thank you so much for the invitation. I would like to present this initiative, and I will try to give some my experience and some discussion about the previous presentation from Professor Benis to perhaps to look for what we can do, and myself what we have done so far for this this network in the Mediterranean. So I'm happy to present this. So the name of this initiative is Medica2C in English. It's a hidden and private French joke, because in France, we do not talk about drugs or pharmaceutical agents. The name as a pharmacist is médicament. So Medica for Medica2C is for médicament, but for Medica2C for Mediterranean Sea, 2C because it's a network for surveillance and it's a vision for the future. And the 2 is because we have funded this network and initiative with my colleague, Dr. Sophie Baron. She's associate professor in my group. And then it's 2 because we have funded this this network together. That is an innovative Mediterranean initiative in the context of One Health. So I will give you some scientific approach of what is the basis and behind this idea. and then how we have implemented this network over the last year. So if it works, yeah. Okay. So just to have a recent look of the problem of antimicrobial resistance, and that's an interesting work that has been published by Nagavi and all, and from the European, Mediterranean and East Mediterranean regional collaborative work published last year at the end of 2025 by Timoslav Mestrovic and his group from Croatia, which shows that in fact the amount of associated or attributable deaths due to antimicrobial resistance in the Eastern Mediterranean region is very high and is believed to double over the next decades. And then it is estimated that around 750,000 deaths could be attributable to antimicrobial resistance in 2050. And then there is some ideas that in order to be able to try to tackle this problem in the world, but in different regions, we need to be able to coordinate surveillance action and platform, what Issam said. But there is a problem also of cooperation and policy, regulation and communication to be able to share those data all together. Of course, within a One Health approach perspective, because it's clear, I will show you that now there is a link and interconnection between the different fields. And then we need to try to develop translational research, because it's not the same socioeconomic things you can do if you are in the north of Europe or if you are in the south in the Mediterranean or in Africa. So we need to tailor what we try to do according to what is possible in the real world, according to each country. So the link between resistance to antibiotic is in fact more complex than I believe myself when I was a young researcher more than 20 years ago. The basis was that antibiotic resistance was linked to antibiotic use. That was the main thing we said every time. That if you use antibiotic either in humans or in animals, you will you will face emergence of resistance to antibiotics. But over the past decades, the concept of One Health or global health has emerged, even if it was known for years that you can find the same bacteria or resistance genes, whatever you look at animals or in humans. Now it's more clear that there are other issues in the biological things that are related to antimicrobial resistance, not only antimicrobial. So there is emerging papers, including in my group, showing that the pollution by anthropogenic activities, including pesticide and other pollutants, may be also associated with resistance to antibiotic. And why it's a new concept is just because Sophie, my collaborator, and me, we are pharmacists. And you have plenty of drugs for which they share the same chemical structure, but they have another name. They are different names. For example, if you look at a well-known glyphosate pesticide, this phosphonic acid structure is likely similar to fosfomycin, that is an antibiotic. But for fosfomycin, you say it's an antibiotic. And for glyphosate, you say it's a pesticide. But in fact, it's the same structural structure, the same chemical structure. And then a microbe is unable to know whether it's an antibiotic or if it's a pesticide. So there is probably things we have not looked for before, is that you can have cross-selection or cross-resistance when you used in the environment one compound that could select for antibiotic resistance in another field. And that's probably one thing we need to do. If you look at the left of this slide, you can see that in the river, in water overall in the world, the main drugs you can find The first one is paracetamol, caffeine, and metformin. These are not antibiotic, but in our group, we show that those compounds are able at different concentration to have inhibitory effect against bacteria, and bacteria can survive to those compounds by dealing and creating system, enzymatic system, for example, that are able to destroy them. So it means that you have in this concept the emergence of a new concept that explains that bacteria are able to develop genes able to resist not to antibiotic but also to different drugs. That's a new concept that explains that in the environmental perspective, you have a bioremediation system. That's nice for depollution. But as a clinician, if you have this bacteria with enzymatic capacities, then you will have a resistance genes that can resist for a treatment for non-communicable disease, for example, for type 2 diabetes. So, but this could not explain, the biological factors could not explain the problem of antimicrobial resistance. And then there are many non-biological compartments that are with the problem of antimicrobial resistance. And of course, in low and middle income countries, everywhere there is a link with resistance and the absence of healthcare access, laboratory diagnostic, the differences between culture, human and social behavior, exchange and demographic evolution, and mainly in some countries, the problem of waste and wastewater treatment and sanitation is clearly linked to antimicrobial resistance. If you look at the last report from the WHO report that was published last year in October, what we can see in those slides is that, in fact, you have an inverse correlation between antibiotic consumption and antimicrobial resistance. What is linked to antimicrobial resistance is mainly poor sanitation, the problem of health infrastructure, and water pollution. And in fact, the more you have resistance level in the country, the less you have surveillance system. That means that if you want to tackle antimicrobial resistance, you need to survey. So there is a need for surveillance system. And of course, there is also a link between antibiotic resistance and the Universal Health System Service Coverage Index. So that's very important to know that the main problem is not the resistance in itself, is the problem of infrastructure and surveillance of those phenomena. And on the right of this slide, you can see that this problem is mainly concerning gram-negative bacteria and resistance to carbapenem compound. And this is a very amazing thing that for the WHO region, you have things that are completely bizarre for a Mediterranean citizen. That's, for example, you have a region whose name is Eastern Mediterranean region. For example, you have Morocco and Tunisia are in this region, according to WHO, but Algeria, that is a neighboring country, is in the African region. So it does not make sense if you look at one specific area, that is the Mediterranean Sea. So that's very interesting to look at this. So how to try to make research on this One Health approach, and what are the questions we should have? And if you see, I'm talking not only on antimicrobial, but also on other drugs, pesticide, pharmaceutical agents, and other pollutants. So if we try to manage this in the One Health perspective, you should look at humans, animals, and environment. And the first thing is to try to know what is the magnitude of this problem or emergence and where. So this initiative is based on the network to try to look at those problems in the Euro-Mediterranean countries in these different sectors, to do epidemiology. We want to know if there is a link between this pollution in the sea because of anthropogenic activities and the link between antimicrobial resistance, but also resistance to other drugs. So we need to have scientific evidence of the problem with environmental factors and pollution. And then the other question is how these bacteria or genes can evolve and circulate between these compartments that need also to encourage a research program on the mechanism of resistance, bacterial immunity, bacterial evolution and speciation, because within this polluted system, in fact, you have a sort of cocktail effect where gene, plasmid, and transposon can be exchanged between bacteria just to adapt to the new ecosystem that is associated with human activities. So that's what I call the research on those compounds. And it's in my institute is the IHU for University Hospital Institute, and it's the U for research. But of course, this can lead to the emergence of high-risk clones. So these high-risk clones should be detected, surveyed, and also we need to get rapid point-of-care tests to detect them. The idea is for human beings to know what is the impact of this evolution in those ecosystems and the emergence of this high-risk clone, not only for infectious disease, as I said, but also for non-communicable disease, because you can have resistance to treatment in non-communicable disease. And the final idea is to try to prevent and to fight against this problem and emergence of high-risk clone, of course, by surveillance, to develop diagnostic tools and therapeutic strategy. That's what I call the hospital and clinic purpose, to try to innovate in terms of therapeutic strategy and diagnostic tools. So now if we go to that, if you want to have some ideas of some One Health papers to understand this, we have recently published with a colleague from Lebanon two special issue with many different mini reviews and papers on this topic published 2 years ago. And you have, if you want to read, you have something like 600 pages of papers to read on this concept. So the problem now is, what are the gaps in the Mediterranean basin? Of course, what we have said before in the first presentation, and the second one is that there is an heterogeneous surveillance system and insufficient data in the Euro-Mediterranean region, especially in the Middle East and North Africa, with wide arrays on AMR knowledge that we don't know what is currently ongoing. There is also a problem on inappropriate use of antibiotics in human, but also in animal as growth promoters. So there is a risk of emergence and transfer of antimicrobial resistance in this ecosystem, either from animals, from water, in the food chain, and because of those contamination that are overlooked, in fact. And there is another problem, is that, as far as I know, there is very, very few studies on the environmental impact of pollution on coastal cities in the Mediterranean by drugs, biocides, and pesticides. And the lack of waste and wastewater treatment make this ecosystem a very hot spot for emergence of new bugs. So if there is the emergence of a specific regional or specific clones, because of the absence of surveillance, you don't know what is circulating. And of course, there is this problem of regional coordination to make One Health approach with parallel strategy, with the lack or the absence of well-done educational programs that are different between countries. So that's the conclusion of what is needed, is to bring together experts from these different fields and sectors to try to establish, firstly, a diagnosis of the problem in the Mediterranean, and to gain insight in order to propose concrete action in the way to tackle antimicrobial resistance, and to be sure to ensure a sustainable development in the Mediterranean. So what is Medica2C? Medica2C is an open and independent international network of experts from Euro-Mediterranean university and hospital, but not only, that is focused on cutting-edge research and education within the One Health framework. The idea is to strengthen research, healthcare, education, and building capacity infrastructure on those problems in the Mediterranean, with 6 main axes we have started to do over the last year to bring experts together in order to be able to collaborate internationally to facilitate consortium for grant proposal, to share knowledge with the problem of regulation law, to be able to share data, epidemiological, clinical, and genomic data, to enhance building capacity and mainly education program and training program for researchers and healthcare workers, to be able to enhance skill transfer between North-South, South-South countries. Where you are not good, you should be able to go in another place to get these skills, to share good practice and to harmonize protocol in order to have interoperable surveillance system, and of course to provide international recommendation that we agree all together. The idea is to be able to provide concrete recommendation that are real world application and not just an idea or a vision. And then you need to have link with political decision maker and economic stakeholders. And this is associated with a link we should do between academia, industry partnership, and industrial partners. So now let's go to why Marseille. Marseille, as you know, is an old city at the crossroad of different civilization over more than 26 centuries and a long history of infectious disease. Why our institute, IHU in Marseille, we have a recognized expertise. The building you show the picture has been built 6 years ago thanks to the investment from the French government that share together clinicians, infectious disease patients with infections, clinical microbiology lab, research lab, education program, all are inside. It's all-in-one house building to do that with a lot of different technological platform, and we have a lot of experience for training. So why us and why no? As you can see, one is an old guy and the other one is a young woman. And the idea is a transmission, the transmission, intergenerational transmission of something that could build for the future. And that's why we decided to do that together with Sophie. And myself, I have a long experience on antimicrobial resistance over the last 20 years. I am currently the scientific director of this institute. I have been elected and appointed this month as the science officer of the SMID-SGAR study group. I have a long experience of valorization of and patents in the institute. I have published some papers, and of course, I have also the experience of editing. I was the editor-in-chief of the IGA for 8 years. I already have been director and trustee of an international society. And I have experience of international conference. And Sophie will replace me when I will retire, I hope. How to implement what we have done so far. So if you look at the middle of this slide, is what we have done firstly locally. Locally means in Marseille city, we have made partnership agreements, signatures, as well as memorandum of understanding with our university, Aix-Marseille, the city of Marseille and the region South, that is for civil society, local authorities, but also with the Ministry of Foreign Affairs at the French level, national level, the Hospital of Marseille, the Euro-Mediterranean University Consortium, TETIS, so that the ecosystem is clear. But also we have federated within that all the innovation and transfer actors and industrial partners from this area. That's for the local partnership. But we also have extended this for the national and international with Euro-Mediterranean University Partnership Agreements, with the Mediterranean University Hospital network from my institution, but also for industrial partners such as Institut Mérieux, Infectious Disease Cluster for Innovation, the Fondation Mérieux for philanthropic activities and helping to build infrastructure, the Institut de Recherche pour le Développement. And all of this was also held and supported by the European Study Group of Antibiotic Resistance, for which I've been appointed as science officer. And this also has been reported and supported by the One Health Summit that was held in Lyon this month. So that's what we are so far. It means that's the partnership agreement and the memorandum of understanding we have signed with partners from the Euro-Mediterranean countries. That means that we have signed around 30 partnership with 15 Euro-Mediterranean countries and universities. So that's what we have done so far with all countries that are mainly representative. From the north, from the south, we have a code of conduct that means that you need to be 2 persons, a young, a old, so a junior and a senior profile, a girl, a man, and partnership with north and south according to the different study group we are currently building. We have done the same for university hospital to have a medicine doctor and physician with a partnership with different hospitals in the Mediterranean basin. But now the problem was that we need also to have representative of other authorities. And then we are currently working with the pastor network, with the ERD representative, and of course we are supported by Fondation Mérieux, that is also engaged in a bilateral or multilateral association with different countries for infrastructure and building to get together an overview of what we can do with each country. So the roadmap of this that was started 1 year ago is at that time divided in 4 parts: the governance, the education, the surveillance and valorization. And to try to get sustainable finance to do that, we try to always have co-financing, 1 part from Europe and 1 part for partners. And then we already have identified for this different section grant proposal for which we apply step by step. And for example, we just have applied for a Marie Curie co-fund postdoctoral program in Europe with many partners. We have the website for which you can have a look if you want. You just have to make a picture of the QR code. So that's for the website that will be improve step by step, and we have planned with partners to make a first report at the end of this year on the gap and knowledge regarding antimicrobial resistance in the Mediterranean countries. As for communication, we also have an international conference that is supported by ESCMID, ESGAR Study Group, and the Hellenic Republic University, National and Capodistria University, and the Hellenic Society for Microbiology that will be in 3 weeks in Athens from 20 to 23 of May, where we will have a symposium on this initiative with different partners. We have already submitted this postdoctoral grant that is 3 million euro of financing with a co-financing with Amidex Foundation in Marseille and the IHU for 10 postdoctoral fellows of each 36 months. And then we have 28 partners for which postdoctoral by bottom-up research program can go for second months in any of these countries or university if their project is able to join the initiative of these partners. And as you can see, we have institute, platform for excellence, but also we have institutional and political cooperating partners, university and hospital, international organization, and all the ecosystem of technology transfer and industry for local actors, but also from national one, in order to be able to build projects that could be innovative in terms of therapeutic strategy or diagnostic. And finally, that's the next step we are working on, is to deposit a cost action at Europe with all our partners. That is to build the network for workshop, conference, webinar. That is exactly what we need to comfort and to enhance our network. And interestingly, for the cost action, 40% of the partners should be under 40 years old. So it's for a junior profile. that will be the next generation to build something that is sustainable in the future. And then I think I have finished. And if you are interested to join this initiative, you can either look at the website with the address here to scan the QR code to be part of this network of experts. You can join it. And I would like to thank you for your attention. And I'm at 26 minutes, Roger. Thank you.
Thank you very much, Jean-Marc, for this very exhaustive and deep presentation. Thank you very much. Actually, we already have a question for you on the chat, but if you agree, I will save it for the end. After all the presentation, we have a question from Charles Strode, but I will save it for later. And I suggest we move to the next speaker, who is Dr. Tarini Jayaprakash from McGill University in Montreal, in Canada. And she's going to talk about AMR. And to talk, her talk will be addressing implementation challenges of the One Health framework in the fight against antimicrobial resistance, a policy brief. So a different approach and also very interesting. So thank you. So please, Tarini, the floor is yours.
Thank you so much. And thank you so much for having me today. Just a small correction though, I'm not a doctor, I'm just a master's student. But thank you. So hi everyone. Today I'm going to be walking you through a policy brief that my team and I have just finished working on. It looks at the implementation challenges of the One Health framework and the fight against antimicrobial resistance, or AMR. So the main argument that we're trying to hold here is pretty simple. We actually have a lot of AMR plans and strategies out there already, where countries around the world have written them down and have accepted that One Health is a good framework to adopt for AMR plans. But what we don't have is a clear sense of how to actually get past the implementation barriers that exist in building these plans and executing them on the ground. So even though many countries have adopted multi-sectoral action plans, the struggle is turning these commitments into solid actions that are coordinated, funded, and measurable. So in this presentation, I'll focus on three things: why AMR is such an urgent systems level problem, why One Health is the right framework for tackling it, and what governments and international partners can and need to do to make implementation possible on the ground. Okay. So let's start with the scale of the problem because it's really hard to ignore. In 2021, about 1.14 million deaths were directly caused by bacterial AMR. And in 2019, nearly 5 million deaths were caused by AMR, were associated with AMR more broadly. If nothing changes, projections show that this could rise to 10 million deaths per year by 2050. Now, here's what's really what really matters from a policy perspective is that this burden isn't spread evenly. Low and middle income countries are hit the hardest, and the consequences go far beyond just infectious diseases. AMR threatens things like routine surgery, cancer treatment, maternal and newborn care, and basically the entire resilience of an entire health system can be affected by antimicrobial resistance. So this is just to establish that this isn't just a clinical issue, it's a developmental issue and a health systems issue, and also an economic issue. One of the key ideas in our paper that we're presenting is that AMR is driven by interconnected systems. Resistant pathogens can move between human health, animal health, and the environment. And they spread through hospitals, food production, wastewater, and how antibiotics are used across different sectors. That means that no single ministry or discipline can solve this on its own, and that different parts of the government need to rely on each other to be able to address this problem. And that's exactly why the One Health approach has been so widely endorsed. It reflects how resistance actually emerges and spreads in the real world. And it's also why 170 countries have already adopted and developed multi-sectoral national action plans with the One Health framework. So the framework itself isn't the problem. The problem is whether these countries can actually make it work across institutions that often have different mandates, budgets, and priorities. So this slide gets into the heart of the implementation gap. We found that while 170 countries have written national action plans, only about 27% actually have effective implementation strategies. And only a tiny fraction of these have dedicated budgets for the One Health framework. So again, acceptance is high, but execution is weak. And this brief that we worked on identifies three institutional problems that tend to reinforce each other. First, is governance, where coordination bodies often exist, but they don't have the authority to be able to direct actions across sectors. Second is funding. Money is often short-term, project-based, and stuck in silos. And the third is surveillance, where data is still very fragmented across human, animal, and environmental sectors. What's important here is that these problems aren't separate and they tend to, again, affect each other. So weak governance can mean that it's harder to allocate and align budgets. This results in weak financing, and weak financing then makes it really hard to build durable systems. And for surveillance, and a weak surveillance means that it's harder to know if any of it is actually working on the ground, despite the plans existing. So to write this policy brief and to find the evidence for it, we conducted a literature review across 58 different studies. 50 different studies that we extracted data from. And across these studies, we conducted a country-level analysis. What stood out the most was that the same structural problems show up in very different ways in different countries and different settings. So in Mexico, for example, there's a formal stewardship structure that exists, but funding and permanent staff time is limited. In Denmark, which is often seen as a very strong performer, experts still say that they need a stronger formal cross-sector coordination. Japan shows how AMR can be better embedded into broader health systems and structures. Bangladesh highlights uneven funding across the different sectors. A couple of more positive examples, though, is one where Vietnam shows progress through digital and interoperable surveillance. And Canada gives an example of growing environmental surveillance capacity as well. So the pattern is pretty consistent. Implementation works when countries build real institutional capacity behind the commitments they make in their action plans. We also conducted a geospatial regression analysis that also shows and addresses an important regional insight, where high burden clustering in areas like South Asia, for instance, suggests that AMR isn't just a domestic issue, it's transboundary and can easily travel across different countries. This again strengthens the case for us to have cross-border cooperation and get across the different countries. So to get into the meat of the policy brief, we have the recommendations. So what is it that we can do about these problems? The first recommendation that we came up with is to mandate integrated governance by law or decree. So we argue that countries need a high-level interministerial AMR council with actual decision-making power. Why does this matter? Because most current coordination bodies are only exist at the advisory capacity. So they're able to sort of write policy briefs, make suggestions, but they don't have any actual power to be able to bring people together. And they don't have any real control or authority across the ministries. So our recommendation is for a legally mandated body that would work very differently, where it could set joint targets across human health, animal health, and the environment. And it should be chaired by a senior political leader. And this is to ensure that we have a high-level buy-in and that we are able to resolve conflicts that might erupt across the different sectors of human, animal, and environmental health. So the point is to move from informal coordination to actual authority, and without that, One Health stays as more of an aspiration than an operable system. The second recommendation is financing. So it's to create a more sustainable financing system. Right now, one of the biggest obstacles, as I'm sure we all know, is that AMR funding is very short-term, fragmented, and tied to individual projects. This makes it really hard to work and support cross-sectoral work, especially things like surveillance platforms or joint stewardship programs. So we propose three different approaches. So the first is to have a national One Health AMR funds that pools public money, donor support, and philanthropic resources. So this basically means that instead of having short-term budgets for different projects that happen individually, we would have one large fund into which different sources of money go into. And we're able to have, as a result, a more streamlined and sustainable source of funding for any work that might involve AMR resistance through a One Health framework. The second is to pilot impact bonds, where investors can provide upfront capital and get paid back only if a measurable outcome is achieved. This is especially relevant for any pharmaceutical companies and having a partnership between them and the government to be able to ensure efficiency and an additional source of funding for any government initiatives. The third is to have a national expenditure review. This is more important than we might tend to believe because it's important to identify where existing health, agriculture, and environmental spending can be better aligned to be used more effectively. What's really important about this recommendation is that it doesn't assume or state that governments need to find an entirely new source of money. It focuses on better alignment and a smarter use of resources that already exist. Some of the some of the next the next recommendation, I'm sorry, is surveillance. So it's to treat unified surveillance as a public good. So this is a really important shift in framing. Surveillance is often seen as a technical issue that's sort of put on the side, or it's just one amongst a long list of measures to take. But we argue that it's actually a very important accountability mechanism for the entire AMR response. Without shared data, policymakers are working with only partial visibility. So we recommend investing in an integrated digital platform that combines data from hospitals, veterinary systems, labs, and environmental monitoring. This system should use common structures and support regular joint risk assessments across the different agencies. Another key point is that environmental monitoring should not be an afterthought. So it's often just neglected as an unimportant aspect when it comes to human health. But we argue otherwise, where things like wastewater runoff and pharmaceutical effluent are a part of the bigger One Health picture. And leaving these out can create major blind spots in our strategies. So in practical terms, better surveillance means better prioritization, where we're actually able to see which areas need our attention the most, better coordination, and a much stronger basis for accountability. So the next few recommendations, another recommendation is to focus on ground level basic interventions like scaling up infection prevention. So things like WASH and farm biosecurity, aligning stewardship measures for clinicians and veterinarians, and tightening rules on over-the-counter over-the-counter antibiotic sales. So this is obviously very important, where it's important to mandate prescriptions, or at least a close follow-up by the different pharmaceutical companies that are selling the products. If there's a way for them to monitor what the patients are buying and why they're buying it for, and if they're able to follow their course through to the end of their sickness period. The second is that we call for a stronger accountability and substantial engagement, where national strategies only become real when provinces within a country, or states and districts, can adapt them in a local context. So if we have something at just the federal or the central government level, then we won't be able to adopt these to smaller towns, cities, and villages where the problems do tend to start from. So public dashboards, local implementation plans, and civil society oversight can all help to create a pressure of follow-through at the local level. The third is to have international support needs that also need to shift. Global partners have spent a lot of energy in encouraging countries to develop plans. And this has happened. We have become successful with this now, where countries have developed their own version of national action plans. Our next step then should be that the plans should focus more on execution. So for global partners to support governance strategies, long-term financing, and practical integration of data systems. So addressing all the three major blind spots that we've outlined in this policy brief. So to close, the core message of the brief is that the next phase of the AMR response has to be implementation-centric. So the real test for One Health now is that what remains is just a guiding idea. Or whether it becomes a functioning system that is actually able to produce results. Our biggest sort of motive for writing this policy brief was that we didn't want to have just another sort of theoretical framework. We wanted to suggest proper implementation strategies that people and countries could use at a practical level. So the challenge is no longer whether we are able to accept AMR, but if we're able to build the governance, financing, and the systems that we need to deliver them on the ground. Thank you.
Thank you very much, Tarini. Thank you. Thank you. Very different perspective, and also very interesting perspective. And just like I said before, we're going to keep all questions for the end. And so now moving to the next speaker, who is me. I'm going to close this series of presentation. Then we will have the discussion. And so I'm going to talk about something a bit different, which is my personal perspective of One Health, and also the perspective of a virologist of what One Health could be. So the title of my presentation is Static or Dynamic: One Health and the Cryptic Dynamic of Emerging Viral Diseases. So let me share my screen. Up. Can you see it?
Yes.
Yes. Okay, very good. Okay. So if you see it, so this is the last presentation. So I'm going to talk about something a bit different from the other presentation, and to address some questions we rarely address actually, and really to talk about something extremely important, because it is the key word, is the word perception. Everything is a matter of perception. Depends how we perceive things. And we have to realize from now on that we don't work on the biological reality. We work on our perception of the biological reality, and we work on our representation of the biological reality. And our representation is shaped, or in other words, is biased by our culture and by the words we are using. And that is very important because words are shaping our way of thinking, our representation of the reality, and thus the way we believe things work. Not necessarily the way they work, the way we believe they work. And that is generating a whole series of problems. Very first example of that, a concept everybody knows or think they know, the concept of species. Species is the concept from the 18th century, not 17th, 18th century, made for classification on morphological traits. Yeah? And basically, especially with Carl von Linné, all specimens with the same selected traits belong to the same species and then receive the same name. And all members of the same species are therefore considered similar. Okay? Individual specimens which are different, they therefore belong to a different species. Okay? The concept of species is a unifying concept, is static concept. Now, if I see it from a different angle and I replace the word species by meta-population, which is the concept of the 20th century, based on genetics and on the concept of population, where the basic unit is not the species, but the population. And what is a population? It's a group of specimens sharing most of their genome. Thus, they are interfertile, which is also the definition of species, but displaying a limited variation and specificities in their genome, which translate in a phenotype. They are different, maybe also morphologically or physiologically different. These populations coexist. They can be geographically isolated or mixed with others at different times. And therefore, new populations within the meta-population are created by admixture of two initial populations. So therefore, a meta-population is the population of populations, a group of interfertile populations which can be isolated or in contact at different times and can exchange genetic traits. Okay? In opposition to species, metapopulation is a diversifying concept. Okay? And metapopulation is a dynamic concept, always in evolution. When an isolated population loses its capacity to reproduce with other members of the metapopulation, it becomes isolated, and therefore it becomes the basis of a new metapopulation. So you see, it's the first example of how words can shape our understanding. Another example, very common, viruses. But the status of viruses depends on our representation of life. Let's ask the question, what is a living organism? If our definition is that a living organism must move, like us, then plants are not alive. If a living organism must be multicellular, like us, then bacteria, archaea, and viruses are not alive. If life corresponds to the cellular world, like us, then viruses are not alive. Okay? And depends the kind of definition we give and the words we use. Unifying visions systematically lead to a biased interpretation. But we have to keep in mind that life is diverse. We have actually 4 realms to consider: eukaryotes, us, which is cellular; bacteria, which are cellular; archaea, which are cellular, but also viruses, which are not cellular, but nevertheless part of the living world. Life is more complex than just cellular life, but we tend to consider ourselves as the model. And viruses have multiple origins. And the biodiversity of the precellular life was certainly huge, especially before the big oxidation event. And the diversity of virus shape and genome we can see today reflects this initial biodiversity. And it's a matter of evolution, adaptation, and survival. We should keep in mind that viruses are among the most ancient forms of life. Okay, and virus make simply a separate realm parallel to the cellular world. If we consider what happens, we previously had a precellular evolution, okay, with primordial RNA, DNA, RNA world, protein world, DNA world. Then later on, the cellular evolution came into the game, and the cellular world developed. We belong to that world of cellular world, but we are not the only one. Parallel to us, there is another world coming directly from this initial life, which are the viruses. They are not cellular, but they are alive and parallel to us. And in fact, the cellular world, the back and forth, we coexist. But we have also to realize that the world today, our planet, belongs to viruses, not to us. We don't own it, we just rent it. Okay, it's really the world of viruses. So there are several things that we should consider in biology and in infectiology, and we should learn from physics. One first thing we should learn from physics, the first one, is anthropocentrism and observer bias. If we go back to physics, we can go back to the Copernican revolution and before Copernicus, Galileo, and where before Galileo had to withdraw because Inquisition, Copernicus stand firm on that. And before that, we had what we call the Aristotle universe, and which was centered on Earth. Everything was moving around the Earth. And Copernicus said, no, it's just a matter of perception. Things are revolving around the sun, including Earth. It's simply the relative movement of the different planets and stars, etc., that make us believe that everything revolves around Earth. It's simply the observer bias. Why? Because every morning we see the sun rising in the east, at noon is above our head, and in the evening the sun is setting on the west, and that every day. So basic conclusion is, it's obvious, the sun is revolving around us. But no, it's an observer bias. It's not like this. We believe it is like this, but it is not the reality. We had the same system with when it comes to biology and especially to medicine, because medicine is anthropocentric by definition. Okay. And when it comes to diseases, we believe that everything revolves around humans, and we are the humans, and every disease is coming towards us because we see only us. But no, it's a biased vision. We are part of a bigger game where there is of metapopulations of viruses coming from one host to another. And there is no difference for a virus between species. Species doesn't mean anything. What is important for a virus is only two things: whether the virus can recognize a receptor and whether the virus can overcome the innate immunity. If the virus can answer both of these questions, then there is potentially an infection that can be established. And viruses can move from any species or any population, any metapopulation, any population of this metapopulation, considering viruses are also organized in metapopulations, and from any direction. So if you use our words, from animal to animal, animal to humans, or humans to humans. The correct wording would be to use from any kind of population to any kind of population. At one level, there could be an animal-human interface. So, the second things biology should learn from physics beyond the Copernican revolution is the quantum revolution. We should do that as well. And we should understand and recognize the quantum dimension of viruses. Of course, it's not particle, but the philosophy and the model is the very same. Why do I say that? Because viruses mutate a lot, especially the RNA viruses, which are responsible for the so-called zoonotic diseases. Zoonotic viruses, except for one exception, the mpox, they are all RNA viruses. And what do we have, which is very specific in this kind of viruses, is that their replication system, their polymerase, the RDRP, so RNA-dependent RNA polymerase, is a complete disaster. This protein is making so much errors that RNA viruses should not exist. But they do exist. So what happens? There is something somewhere. Well, there is a specific evolutionary and adaptive mechanism based on numerous mutation and cooperation between variants. It's the quasi-species system. And there is no fixation of mutation over time. Each generation, the virus explores all possibilities. And each variant carries only 2-3 mutations, but altogether they cover all possibilities of mutation, what we call the sequence space. And it's a permanent production and permanent elimination of variants. Okay? Most of these variants are zombies. They are not viable. They appear and they disappear immediately. But here and there, certain mutations allow to overcome the host difference, and there's also a mechanism of cooperation, and these surviving variants are the basis for a new generation, okay? And human emerging viruses are RNA viruses. It is not a coincidence. It's simply because these kind of viruses are naturally multi-host viruses. They are meant for that. They have evolved for that. And why a quantum dimension? If we go back to the early 20th century, in the late 1920s, there was in Denmark, in Copenhagen, a group of scientists who gathered around Niels Bohr here on the left, with without the jacket, and Niels Bohr gathered a group of people in his lab. That's why it was called the Copenhagen School, and among them was Werner Heisenberg, a German scientist, the father of Earth uncertainty, and together they came up with a very important concept, which was called the Copenhagen interpretation, or also the collapse of the wave function. What did they say? They said that when there is no measurement, particles are in X states, a certain number of states, we don't know how many actually. So there are X states. But whenever we measure, we isolate, basically by random, one of these states, and we know only that one, which has been isolated by the measurement. But this is a consequence of the measurement, and the consequence of this measurement is the collapse, what they call the collapse of the wave function. Now, if I move to viruses, but of course it's not particles, but the philosophy is exactly the same. We don't have a collapse of the wave function, but we do have a collapse of the sequence function, because when we do sequencing, before sequencing, especially because of this quasi-species system of evolution and exploration of the sequence space, where all possibilities of mutation are covered in different variants, we have X states, plenty of variants with different mutations together and cooperating. But when we sequence, we extract only one. So we have the collapse of the sequence function. It's even a double collapse, because we get only one sequence, the consensus sequence, which is actually a default sequence. But it's also another collapse, because doing so and getting the consensus sequence, we eliminate all these mutation carried only by a few variants, which are very important in the evolution adaptation of the virus, but they are just eliminated because we keep only the consensus sequence. So we therefore end up with a false impression of uniqueness. And we end up in a situation where we consider there is the disease, only one, which is wrong, because disease is the reaction of the patient. We have only the virus, only one, which is totally wrong, because we have a crowd of different viruses. And we have the sequence, the only one, which again is totally wrong, because we do have plenty of different sequences. But this is erased by the sequencing approach. And we only know this virus and this sequence, and they become the only ones. But they are not the only ones. They are only those which have been observed basically by random among a multitude of possibilities. And nothing is unique, including the disease, because the symptoms vary from one individual to another. And we come up to a situation where the perception is replacing the reality, okay? And important to consider that a virus causing an emerging disease is not predestinated to that. It is the result of a stochastic process. It is an accident resulting from the combination of multiple variables. And it will never happen the same. It's really the same way as quantum physics. And the third thing we should learn from physics is that nothing is created, nothing is lost, and everything is transformed. This was stated by Antoine de Lavoisier before being killed during the French Revolution. And this is very important. This was in physics, and in biology this applies, but it applies through mutations, evolution, and adaptation. And we can quote two very important persons for that. One is Theodosius Dobzhansky, who said that nothing in biology makes sense except in the light of evolution. And of course, Charles Darwin, who said that all living misspell. All living species are in perpetual transformation. And so what is important is that the word shape our way of thinking and of representing the biological reality. It's very important to consider that things are not static, things are dynamic. And one very good example of that, which refers, of course, to emerging diseases, is the concept of spillover. You all heard of that, spillover here, spillover there. But what is spillover? Spillover was termed initially to describe contamination of wildlife by livestock. And it was termed by Peter Daszak in 2000. Then it was later on used as a journalist word, not a scientist word, but a journalist word to describe interspecies transmission to humans by David Quammen, 12 years later. And David just wanted to find a word that will represent this dynamic movement of contamination between different species and mobility. And he used spillover. But it became a very successful word, which invited all spheres from public to scientific. And words influence our representation of the biological reality. Because for people, many people, what spillover? What is spillover? But spillover means spilling over. Inadaptive summation of human-adapted viruses, just like an alien invasion. But therefore, this led to a lot of preconceived ideas with absolutely no demonstration, but become accepted immediately by everybody. So the first preconceived idea is that viruses must be pre-adapted to human to cross the species barrier, but it's wrong. There is no species barrier. Viruses do not, and in this case, viruses do not evolve. They are already adapted for some obscure reason. And even viruses are never considered in spillover definition. And of course, this led to a lot of work and a lot of money spent on screening in the wild to find the so-called reservoirs and the so-called intermediates. And when you go to spillover itself, that no mechanism of spillover was ever described. It's a kind of self-explaining phenomenon. What happened? A spillover. It's enough. No more question, it's a spillover. And the only other thing that is a self-explaining like that, but it's a miracle, which is not really a scientific issue. And the problem with a spillover is that it's all wrong. Okay, many viruses are found in the wild, many, but no human virus was ever found in the wild. No intermediate was ever found in the wild. And however, you have parallel hosts can be infected by the same virus, but no one is intermediate to the other. And intermediate illustrates also a determined orientation, always from wildlife to humans, anthropocentrism again. Spillover is just a journalist's word to qualify interspecies transmission, but it led to a flawed interpretation, a flawed representation of the biological reality, and futile actions looking for something that does not exist, and of course was never found. Okay? And actually, SARS-CoV-2, the virus causing COVID-19, give us the answer. What did we have with SARS-CoV-2? We have a succession of different variants. If we represent it differently, we see that they go up in terms of number of percentage of viruses in the global population. So in terms of demography, they go up. And then after that, they go down, they disappear and replaced by another one, and so on, and so on, and so on. Some go even further, and I called variant of interest, and some even higher, and they are called variant of concern. Okay, so we just have a succession of transient variants all the time. It's the way the viruses evolve. Okay, the variants appear and disappear. It's a permanent evolution. It's a dynamic process of adaptation. Nothing is static. Okay, what is the observed dynamic? If we compare to what happened with COVID-19, but this system of variant is exactly what we saw. We had initially two different populations, A and B. A disappeared in Wuhan, B remained, and gave rise to another population variant which replaced it, alpha, then beta, then delta. Other variants were produced, but they were not very efficient, they were not very competitive, and they disappeared. Okay, but each generation generates a lot of variants, and then some disappear and the other remain. Now, what do we have with the spillover model? We have different interpretations. For instance, the group in Scotland described the fact that viruses must be adapted to humans before going to humans. And so they said that, okay, they evolve in bats from different species until by chance they get adapted to humans, and then they move to humans. They spill over into human, either directly, was never found, either through some non-species like the pangolin was shown to be wrong, or an unknown intermediate species, which was, of course, never found. Other said, oh, since the virus must be adapted to human, since we have two populations, A and B at the beginning, but it means that two different species of animals, were infected by two different viruses, and they both infected and spilled over humans. And after that, what happens? But the viruses which are not evolving started to evolve and give different variants. Actually, that's why we came up with the circulation model, which says something absolutely crazy, is that the virus behaves exactly the same before the disease is described and after. There's no difference. The viruses are doing always the same thing. Before A and B, we have a parental population which receive different names. But this parental population was not transmissible enough to trigger a disease. But this parental population was itself a progeny of a parental one, and so on. And we go back in time until we can find the very first human population infected by the ancestral virus, which is the primary case, and virus involved in humans. And the same happened with all different animal species over time. And remember what I said, we have the cellular world parallel to the virus world. So viruses go back and forth between different species. Species appear, disappear, viruses are still here, and they keep evolving like that by transient variants. And if we go back enough in time, we will find dinosaurs. Okay, virus was still we're still here, but not the same variant. Even the variants we knew at the beginning in Wuhan, they don't exist anymore. Okay, we know them because we have the sequence, we have them in a collection, but they don't exist anymore in the wild. It's a permanent dynamic system. That's exactly what happens, and that's really, to me, the definition of One Health. We have this circulation in the wild of viruses, all direction, and a permanent evolution. Viruses will come sometimes into humans, and then will evolve into humans, but in other species, they will do the same, they will evolve. Okay, but we will have something specific to human, just like we have something specific to other species. Closely related viruses, but never the same. And we do have here, we have one first accident, a genetic one, where virus becomes very, very, very transmissible, but it's not enough to trigger the disease. To trigger the disease, we need an amplification, we need a societal event, which allow the virus to cross the outbreak threshold and then trigger an epidemic, or since humans are traveling a lot, can translate into a pandemic. Okay, and this to me is really a representation of One Health, because we can see the importance of mobility of different species, host of the host, the dynamic and evolution of the different organisms, the wildlife important, the importance of the wildlife sphere, also the importance of the human, the societal phase, the societal sphere, the importance of the society, everything at once, everything plays a role in the emergence of the disease. And I will conclude at that by saying that we always should keep in mind that the cause of the disease is biological, is the pathogen, but the cause of the emergence of the disease is societal. And that, for me, is really what One Health is. It's a combination of everything. So I thank you for your attention, and I will stop here. And if you have any question, we can now open the questions to everybody. Jean-Marc, si Jean-Marc raised the hand, please.
Yes, it's just a comment on your presentation, Roger.
Yes, please.
I agree with your perspectives, but I disagree from some points. The thing is that because I'm working on mobile genetic elements for years, it's not so evident for me. I'm a post-Darwinian guy, so it means that mutation is very slow phenomenon. But the transformation and bacterial evolution and speciation, for bacteria at least, the main thing is a stochastic event. And the stochastic event is the acquisition of something that is outside, a plasmid, a transposon, something like that. And I completely agree with the definition of species that is only by phenotype. But I have a wonderful example in my experience in my research, is that I was the first to sequence and analyze the genome of Enterobacter aerogenes. And then Enterobacter aerogenes, his name was linked to the fact that this bacterium is mobile, okay,
Yes.
thanks to a flagella. And when we sequenced the genome with the Genoscope in France, they called me to say, Jean-Marc, you're sure you have not made a mistake with the bacterium you sent to me, because the core genome is a Klebsiella. And in fact, the definition was Klebsiella is non-mobile bacterium, and Enterobacter is. But in fact, what we found is that Enterobacter aerogenes is a Klebsiella that's acquired from the environment of flagellum. So that means that the definition of words, I agree, was I said that antibiotic could be pesticide. I agree with that. I agree that species should be defined as the phenotype, clinically at least. But just to say that the evolution is only by mutation for bacteria is completely wrong at that time.
Oh, yes. No, I mean, correct. Remember, I was talking about viruses.
Yeah.
And especially RNA viruses. Okay, I agree with you. My talk, that's why it's a viral diseases, and I was talking about the emerging viruses, RNA viruses, and when I say based on sequences on mutation for the virus, also I'm referring to the RNA and to the quasi-species system, which is different. Does not apply necessarily to bacteria or to other and to cellular organisms.
Yes, but what is interesting, a recent paper that is in revision I have done on
Yes.
metformin drug, an anti-diabetic drug, is that in the environment, because of a natural compound very close to anti-diabetic metformin, whose name is galegin, is produced by a plant. And bacteria in the environment, they adapt for years or million years, I don't know, and one chromosomal gene by mutation is now able to hydrolyze the metformin drug. But it's in the chromosome, and then it's a Darwinian evolution. But after that, in fact, there was a transposon that was able to capture these new genes, to put this into a plasmid that spread now as a mobile gene. So you have the both system, the Darwinian mutation evolution, along with after a stochastic event that is the spread by mobile genetic elements.
I fully agree, because system and viruses, the quasi-species is a Darwinian system. Huh?
Yeah.
It is a Darwinian system, and you're right, it's totally stochastic.
Yeah. So
everything is completely
perhaps
stochastic and probabilistic, actually, stochastics and probabilistics, of course. And I fully agree. And what we see, what I wanted to say, that what we see, that's why I refer to the quantum system. What we see is just one among a multitude. That is the resultant of a stochastic combination. It will never happen the same.
Yeah.
Again,
so perhaps now perhaps we need to discuss with the panel on the main topic and how to implement the One Health work all together with different networking groups. So I think it's open to question, perhaps with Issam Benis and Cheryl.
So we can open to question now. It's for the different speakers. So I don't know. I was talking, so I didn't follow the questions on the chat. So what does it say? Okay. Okay, so it's mostly for you, with Cheryl. So it's question on heavy metal, and so maybe you can you can answer these questions. So the questions I see on the chat is for you, Jean-Marc. So maybe you can.
Yes, I just have some discussion with Cheryl about the fact that in the One Health perspective, what I'm working on in my group is that what we found is the cocktail effect by anthropogenic activities between antibiotic, drugs, pesticide, heavy metals, and that in fact the selective pressure in those ecosystems, what we found is that there are genes associated with resistance to, for example, heavy metal or pesticide. They are embedded within transposon that could also have transposon of antibiotic resistance. And that's the same transposon you found for carbapenemase, for example. And then I have this example in Thailand where the pesticides are widely used for crop culture because of GMO plants, okay? And the farmers also use antibiotics for their animals. And then when you look at the bacterial genome you found in this array in human stools, you have bacteria able to resist to pesticide, but also to antibiotics because they are both in the same transposon. So it means that the pressure with pesticide selects for antibiotic resistance. So that's, to my opinion, a very interesting way to discuss about One Health. It means you have something in the environment that is linked to anthropogenic activities that select for resistance for something that has nothing to do with antibiotics. But unfortunately, this system that is mobile is in the same system of transposon where you get an antibiotic resistant gene. So pesticide selects for resistance to antibiotics. That's the One Health way of thinking we should have. But we need to disrupt the sectors and silos to make a cross-sectoral way of thinking.
Thank you, Jean-Marc. Is there any question for any of the speakers? I don't see in the chat. Anyone would like to say something or to? Okay. So I see no question. So if no question, what we'll do is close this session. And no. Oh, clear. Thank you. Okay. So we'll close this session and give the floor to Professor Benis, who is going to give the closing address of this webinar. Please, Sam, the floor is yours. And before that, sorry, I forgot, but I want to thank again and congratulate again all the speakers who talked during this session and the sessions before. So thank you again for your participation and great talk. So I give the hand to Sam Benis.
Thank you, Professor Roger. So,
Yeah, thank you. And it's just for Cheryl, I will be in touch with you by email.
I will do the same. Thank you. So, distinguished colleague and dear friends, we have just lived 2 extraordinary days, 24 speakers and 17 institutions, 13 countries, 3 continents, 6 sessions running on 4 parallel platforms, and 1 shared conviction that human, animal, and environmental health are inseparable. So this is what One Health looks like when it's lived, not just discussed. A few special thanks to Professor Mohammed Adnawi, President of the UMCSS, and Professor Jafar Hikkel from the Mohammed VI Foundation for the institutional trust that made this event possible. Professor Hikkel, your invitation to organize the next edition face-to-face here in Morocco is the most generous gift we could receive at the close of this webinar. To Professor Roger Frutos from CIRAD, who my co-chairs, without your relentless energy, your scientific rigors, and your transcontinental network, this series would simply not exist. Thank you for everything, Roger. To the co-chairs of the One Health Working Group, Professor Chao Nong Zhu from Shanghai Jiaotong University, and Professor Wayumi Wakimoto from Veracruz, Brazil. You are the connective tissue of the global community. To Professor Raman Bidi and the World Federation of the Public Health Association, thank you for the vision and the legitimacy and also the challenge you placed before us today. To each of the 24 speakers, each of you has left a mark of this webinar. And to the technical team behind the scene, especially Amin, our doctoral student, running with the calm and precision, and to all of the students and the researchers who attended this 2 days directly on Zoom or indirectly through the onehealthafrica.com, and to the silent audience, the hundreds of researchers, students, clinicians, and citizens who watched us live on YouTube or on onehealthafrica.com. Thank you. You are the reason we do this. One last word. This conversation does not end here. Tomorrow at 2 p.m. Casablanca time, we continue with our companion webinar dedicated to One Health in the Democratic Republic of Congo, hosted in the same platform. I warmly invite you to join us. And in a few months, I think we can organize a face-to-face, A-to-A such conversation than we started online, and we can move to the walking on the same ground because what can say we concretized more the One Health, One Movement. And these 2 days, we started this webinar with anxiety. Today, we close it with hope, I think. So thank you.
Thank you, Tabenis, Essam. I would like to add a final word on the final word, just to thank and congratulate Professor Benis for the fantastic work he did in hosting, and his team in hosting the webinar and in preparing all information documents, the poster, organizing all the links, etc., which was very complicated. Dr. Professor Benis and his team did a fantastic work in terms of hosting the webinar and organizing the webinar and making everything working well. So, Essam, thank you very much and congratulations, and thank you very much for all the work you did.
From the foundation of Mohammed VI of Science and Health, thank you. And this is an honor and a very pleasure to see that you are satisfied. I hope that it will be also the case for all of the attendees and the panelists. Thank you.
Thank you very much. And thank you to all of you for participating. I think it's time to close now. So thank you all again for absolutely everything. And I wish you all a good evening. Thank you. Thank you very much again.
Bye-bye. Bye-bye.
Bye-bye. Bye-bye. Thank you. Bye-bye.